Dear ladies and gentlemen, it's great honor for us to see all you being here. The International Conference Mental Health Global Challenges of 21st Century continues to gain researchers, social activists, and all interested parties to discuss and solve urgent tasks, urgent challenges of society developing. The International Conference Mental Health Global Challenges of 21st Century is a platform for dissemination of leading ideas and experience, for support of building academic networks, developing future collaborations between researchers across the different regions of the world. This conference is established not as a temporal event, but as a continuing act. That's why we are aiming to join all main actors, all interested parties, I mean governmental institutions, national and international organizations, researchers, professionals, and policymakers. Together in these our activities in order to effectively develop cooperation in the field of mental health care, in order to facilitate social changes. The main conference's results are social awareness raising campaign, geographical diversification, research contributions, partnership building. We establish Mental Health Global Challenges Proceedings and Mental Health Global Challenges Journal. The authors of the international journal Mental Health Global Challenges, ISSN 2612-2138, represent wide geography, North America, Europe, Africa, Asia. Mental Health Global Challenges Journal is also available in National Library of Australia, several universities of Australia, in Henry Project, a library of World Health Organizations. The journal is indexing in DOJ, ERIC Plus, and other scientific databases, and available on Pablos, Clarivate Analytics. Mental Health Global Challenges Journal is part of CLOC's community. This will ensure our authors in sustainable life of their publications. And I would like to clarify that the journal considers with special attention the manuscripts which can be of interest for policymakers and professionals. We organize this conference since 2017, but this year, according to the pandemic COVID-19 situation, we have to organize this conference in online format. In reason that any conference on health must be health-friendly and must protect health of each participant. We are doing the attempt to establish cooperation regarding mental health care globally. So, I am honored to start our session and introduce you our honorable researchers.
Good day, ladies and gentlemen, and honored guests. I'm Dr. Ingrid Daniels, and I'm the President of the World Federation for Mental Health. It is a great honor and opportunity for me to be present today at the 4th International Conference Mental Health Global Challenges of the 21st Century. I will be speaking to you today about the mental health challenges confronting us today. And my presentation is really a call for transformation and decisive action in dealing with mental health challenges of our global citizens. So the mental health landscape, even before COVID-19, was pretty dire. Close to 1 billion people across the world living with a mental disorder. We know that 1 in 4 persons will be affected by mental disorder at some stage of their lives. We also know, according to the World Health Organization, that mental, neurological, and substance use disorders exact an extremely high toll on health outcomes, accounting for 13% of the global burden of disease. And then there's depression. Depression will be the #1 global burden of disease by 2020, surpassing heart diseases and cancers. In the past 5 years, we've seen a 50% increase in common mental disorders, accounting for 615 million people living with depression. Of more concern is the fact that every 40 seconds someone dies by suicide. This is of huge concern to us. Of more concern is the fact that the second lead cause of death amongst our young people, 15 to 29 years old, is suicide. Very concerning, very worrying. And then comes COVID-19. And COVID-19, the global health pandemic, as we know, has impacted on the mental health of millions of people in every nation. This virus not only impacts on health outcomes, but it has this negative symbiotic relationship with mental health, compromising millions infected as well as those affected. Just this morning, the results of a study in the US was released, and of the 69,000 medical records gone through, as well as 62,000 positive COVID-19 cases, they found that 1 in 5 of these patients presented with a mental disorder after having been infected by COVID-19. This is very worrying. This is extremely worrying. So prior to COVID-19, we already had a very bleak picture in terms of the mental health landscape. But then comes COVID-19 and exacerbates a very difficult situation that we had already encountered. So very concerning. But COVID-19 has also pushed into the forefront the social determinants of mental illnesses, such as poverty, gender-based violence, unemployment, increase in substance use, adding to the already dire situation that COVID-19 has presented and layered over an already difficult, bleak situation. So with that as background, one then has to say, so how does the world respond to this? What are the treatment options available? Well, firstly, here's the scenario, which is really concerning, is that 50% of persons in high-income countries have no access to mental health care. And when you look at low and middle-income countries, the situation becomes even dire, with 85 to 90% of persons living in these low middle income settings having no access to mental health care. So these huge treatment gaps against the backdrop of increased and increasing numbers of people living with mental disorders is of huge concern. And our approach largely has been, in terms of treatment protocols, a biomedical approach. It's been the dominant approach to addressing mental disorders. And how far can that go? When you look at where people are living, they live in these dire contexts. They live in these communities where social determinants are at the forefront. And our approach is often a one-size-fits-all. It doesn't, because all of us are individuals with our own personalities, with our own responses. We all respond differently to different contexts and situations, and we come from different backgrounds. So one size does not fit all when it comes to treatment. And then when you look at the very bleak picture in terms of prevalence, large treatment gaps, one has to ask, what has the responsibility of governments been in investing in mental health? Well, sadly, on average, only 2% of health budgets are spent on mental health. Ladies and gentlemen, I rest my case, because there's no way that 2% is going to address these large treatment gaps, which will get larger because of COVID-19's impact on mental health. COVID-19 is not only a health emergency, it is a mental health emergency as well. And 2% investment is not going to do it. So we need transformation in the way budgets are allocated, the way money is spent, the investment call. So under COVID-19 conditions, we call for not only an increase in the health spend, but also the mental health spend. So it's time for action. It's time for action. We need urgent interventions to address these large populations who are now presenting with mental health challenges as well as mental disorders. Today is the time that these actions need to be put in place. It is therefore no wonder that the World Federation for Mental Health, as its World Mental Health Day theme, was very clear call for mental health for all, greater investment, greater access, because we know with greater investment in mental health, there'll be more access to community-based interventions, and with greater access means that people have access to care, but they have access to live dignified lives within their communities. So the call for action is very clear. The Secretary General of the United Nations, Antonio Guterres, in May said that in many countries, COVID-19 is leading to cuts in mental health services and the closure of facilities. Worrying, very worrying. And he says, unless we act now to address the mental health needs associated with the pandemic, there will be enormous long-term consequences for families, communities, and societies. A very clear warning. We need to shift the agenda and prioritize mental health now more than ever. Unless we act now, he says, to address the mental health needs associated with the pandemic, there will be enormous long-term consequences for families, communities, and societies. Dr. Tedros Ghebreyesus, Director General of the World Health Organization, stated, he said that mental health must become an integral part of the universal health coverage. But most of all, he says that nobody should be denied access to mental health care because he or she is poor or live in remote communities. A very clear call. And so we need to shift our approach. The way in which we have delivered mental health services definitely is not going to close the treatment gap. We're going to have to think creatively. We're going to have to think innovatively about how we can provide cost-effective services to all who need it. So the rising burden of mental disorders in all countries requires immediate and drastic actions, informed by a rich body of evidence on delivering innovative mental health services in a diverse context. Failure to do so will mean that we will not achieve the universal health coverage outcomes, and we'll have large populations of people living with mental illness uncared for. And so universal health coverage refers not just to coverage of populations, but the coverage of a full range of health needs, of which mental health needs to be prioritized. And so we've got to bring about transformation in our approach, because this dominant medical model approach is not going to do it. It's important. Let me say that. Very important. However, we need to shift our approach. We need to have an integrated approach which takes into account biomedical as well as psychosocial interventions. And these psychosocial interventions operate at the interface between the individual, the interpersonal network, and the wider social context in which they live and operate. So we can't talk about treatment only from a medication angle or a medical treatment option angle. It's got to be holistic. It's got to be integrated. And it does call for us to think differently about how we intervene. Person-centered approaches is of critical importance. The voice of a person with a lived experience in the context of his or her treatment is of the utmost importance if we're wanting to see better recovery journey results. And so our approach needs to shift. We need to think of a multi-sectoral and intersectoral approach to mental health. The human resources available, particularly in low and middle income countries, in the treatment of mental illness is significantly reduced. There are insufficient psychiatrists, insufficient psychiatric nurses, insufficient psychologists, insufficient social workers, and I can go down the list. It will not do it. But here's the thing, we do have an option. We have the option to think creatively about how we call and pull on board non-specialists in the treatment space. And these include the mental health service user as someone with a lived experience, someone with the exposure to treatments and know what happens at community level. So we call for greater peer interventions and peer support. We call for the inclusion of mental health volunteers, community health workers, traditional healers, as well as faith healers to come on board. So we're looking at a cadre of mental health service providers that are not only mental health professionals, but it's a combination of mental health professionals and others who are trained, who are supported to identify, to refer, to advise, and ensure that everyone comes into the treatment loop. But this shift does require that we move away from the more dominant approaches to an integrated approach, which is biopsychosocial approaches to care. And so Patel and Saxena in 2019 stated that the primary health care must be the foundation to realize unmet needs for mental health care globally. Achieving this, however, they say, will require fundamental re-engineering. And I want to stop there. Fundamental re-engineering of the way that primary health care is conceptualized, first of all, organized and delivered. And this, in turn, will need full engagement and support of all actors, I just mentioned a few, in universal healthcare, not least of all but the people also affected by mental disorders. And so we also call for greater investment. We call for greater health budget spend in mental health. 2% will not do it. Because here's the thing, we know that for every dollar invested in mental health, there is a $4 return on that investment in terms of health outcomes, but also the economic productivity of that individual and for the country's economy. So the health economics is very clear. The justification for this investment call cannot be ignored, because we know that the Lancet Commission indicated that we will be spending by 2030 $16 trillion on mental health if we don't address this clarion call for greater investment now more than ever. And so the key messages that I'd like to bring this morning is we need greater investment in mental health. We need political will. We need activists and advocates in mental health to ensure that mental health becomes a reality for all global citizens, for every community, for every country. This transformation in mental health systems needs to prioritize mental health. We need to shift our current approaches. We need to re-engineer. We need to redesign. And at the core of all of this, mental health is a human rights. Everyone, everywhere, has the right to mental health care, now more than ever, particularly during these COVID-19 pandemic times. We call for quality, accessible primary health care to be the foundation on which we will build and ensure universal health coverage, which includes in that a mental health response. And we want to make mental health a reality for all, for everyone, everywhere, even if they're poor, even if they live in remote communities. We have an obligation, we have a responsibility. It was Professor Pamela Collins and Professor Deepa Reho who had a very clear call during World Mental Health Day, it's call for action. And they said, very clearly, they said that the Sustainable Development Goals, ladies and gentlemen, and the targets cannot be achieved without social justice and investment in mental health. So, the motivation is clear. The justification is clear. We've got the research. We've got good, innovative, cost-effective practices that can be implemented. And we can shift our approach. And we have to change and shift our approach if we are serious about delivering mental health for all. We need transformation in mental health. We need our policies and our laws to ensure that that mental health is high up on that agenda. That when we talk about COVID-19 responses and policies for implementation, mental health needs to be up there, right in front. And so we call for the shift. We call for this transformation. We call for this rethinking. You know, the COVID-19 pandemic has also presented us with opportunities. In the virtual spaces that we operate, there are no boundaries anymore. I mean, here I am in South Africa speaking to you today. So these virtual opportunities allow us to break down the borders that existed before in terms of reach. And that applies at country level as well. And so this call for mental health now more than ever is of critical importance. So everyone, everywhere, ladies and gentlemen, is deserving of mental health now and beyond COVID-19. We should leave no one behind. No one should be left behind. And without real action, our calls for greater investment in mental health, our calls for leaving no one behind, everyone, everywhere becomes just a slogan. If there's no shift in the mental health upscaling and ensuring that all have access. And so the time for action is now. The litmus test for social transformation is the extent to which the most marginalized in our society are afforded dignity and equal access to opportunities for personal development and socioeconomic development. The most vulnerable often are people who live with mental illnesses daily. We have an obligation, we have a responsibility. All of us have a role to play to invest in mental health and making it a reality for all. The time to act is now, not yesterday, not tomorrow, but now. And so I hope that during the course of the conference, that you'll engage in these dialogues and that you'd come up with additional interventions and innovations to facilitate the closing of the treatment gap. That there'll be greater call for investment in mental health, there'll be a greater call for the prioritization of mental health in the COVID-19 pandemic times, now more than ever. I thank you, and I wish you well with your proceedings today.
Okay, so basically we'll be looking at virtual reality. Just a minute. The question is virtual reality, the new technique. This particular topic stems from my findings about the use of virtual reality for therapy and why I think it's the way to go. And so I hope that at the end of this presentation, you will actually understand where I am coming from. So come along with me and let's look at this all together. So we begin by looking at what virtual reality really means. Now, virtual reality on a plain level, right? Virtual reality is defined as a computer-generated simulation, such as a set of images and sounds that represent a real place or situation that can be interacted with in a seemingly real or physical way by a person using a special electronic equipment. It can transmit visual, auditory, and various sensations to users through a headset to make them feel as if they're in a virtual or imagined environment. From the picture here, you can see this particular person wearing something like a headset. So this is the headset that is used for virtual reality. Now, it's interesting to know that the concept of VR was introduced in the 1950s, and the maturity of VR for entertainment is now evident. Currently, more than 230 companies are producing various products related to VR and performing research and development, including global companies as Samsung Electronics, Apple, Facebook, Amazon, and Microsoft. In fact, VR systems now exist everywhere, and they consist of VR headsets, a computer, and video. Recently, chairs, gloves, and sensors have been added. VR headsets refer to head-mounted goggles, which you can see in this picture here. They're equipped with a speaker or headphones. VR systems that include the transmission of vibrations and other sensations to the user through a game controller or gloves or chairs are known as haptic feedback systems. So there are times that it might be necessary to have a form of feedback, right? So some people call essence, what is called essence rather, and attach the fingers to get feedback from the individual wearing the headset. Now, consider that mental disorders are among the leading causes of ill health and disability worldwide. VR is a welcome additional treatment. Studies have already shown that VR can ease certain phobias, treat PTSD, help people with psychotic disorders experience less paranoia and anxiety in public settings, and reduce social anxiety. Today, the VR technology is applied to advanced fields of medicine, engineering, education, design, training, and entertainment. And like we said, it's a computer interface which tries to mimic the real world beyond the flat monitor to give an immersive 3D, that's three-dimensional visual experience. Often it is hard to construct the scales and distance between objects in static, so it stores a 3D helps to bring the depth to objects. So this is why VR, virtual reality, uses 3D for their environment rather than using 2D, which may appear static at all. But to interest you to know that VR is now being used in mental health across the world, and that's because it has been seen to contribute to the recovery of people with mental disorders. So we cannot take that away. Still looking at historical background of VR, the term VR was coined by Jaron Lanier in 1987. The development of VR can be traced to 1957 when Morton Haley, a cinematographer, conceptualized that audiences would be more effectively drawn into the stories if all their senses are stimulated. Right. In 1960, he built the Sensorama that included a stereoscopic color display, fans to provide wind, odor emitters, stereo sound system, and a moving chair to simulate motion. However, the system was not interactive. The first head-mounted display, HMD, named as Headside, was developed by Philco Corporation in 1961. It's linked to a circuit closed camera system. The HMD was mainly intended for use in dangerous situations as the user could observe a real environment remotely. It was used in military training operations and by helicopter pilots to have a clear field of view while flying in the dark. Some statistics here. The next modern advancement in 1966 was when Eva Sutherland developed the Son of Damocles system using HMD connected to a computer, in which a person could look into a virtual world that would appear as real as the actual world user would be. So after the experiment by Lanier, then Morton followed, right? But his own didn't really give that kind of experience, even though it was used by military personnel. But along the line, Sutherland Ivan came up and developed his own system called the Sword of Damocles. This time around, the HMD was connected to a computer. This kind of gave people a look into a virtual world that would appear as real. Some of us here have actually watched movies in 3D before, and you can tell what the experience was like. So imagine if you're able to see beyond just a movie, you're able to see what exactly is happening in the world beyond you, where you can't be there, but everything appears as though you are there. Early application of the technology were in designing vehicle simulators. Then later it was mainly used for training military personnel, pilots, astronauts, but largely remained out of public eye. Let me give us a bit of statistics, right? Now, the computer maintained the virtual world in real time by tracking the user's hand movement so that the field of view would change appropriately and the user looked around. In addition, for the first time, the user could manipulate virtual objects in a realistic way. The combined effect was a substitution of sensory data from a natural world with sensory data about an imaginary world. The sensory data from imaginary world or virtual world change in response to users' actions, resulting in a sense of presence. Till date, there has been 25 years of research going on as regards virtual therapy, and it keeps increasing year after year. Now let's look at application of virtual reality in therapy. Now, virtual reality therapy, also known as VRT, is also known as virtual reality immersion therapy, simulation for therapy, virtual reality exposure therapy, and computerized CBT. It is the use of virtual reality technology for psychological or occupational therapy and in affecting virtual rehabilitation. In many environmental phobias, reaction to the perceived hazards such as height, speaking in public, flying, close spaces are usually triggered by visual and auditory stimuli. VR exposure, as compared to in vivo exposure, has the advantage of providing the patient a vivid experience without the associated risks or costs. VRT has great promise since it historically produces a cure, in quote, about 90% of the time at about half the cost of traditional cognitive behavioral therapy authority, and is especially promising as a treatment for PTSD. VR therapy provides the opportunity for mental health professionals to not only reproduce real-life scenarios, but to also adapt and control this environment to suit the individual needs of their client. Because you're able to take them into the environment that they really need to be, so it gives you the opportunity to actually expose them to what you want them to know. You are able to show them what they need to know per time. And that's the big thing about virtual reality therapy. Together with the arrival of new technologies in mental health, doubts and questions about their effectiveness and contribution regarding traditional treatments increase. Amanda A. Bembo and Paige L. Anderson published in the Journal of Anxiety Disorder a meta-analysis that attempts to compare attrition in the psychological treatment of anxiety with in vivo exposure compared to the use of virtual reality. With attrition, researchers referred to discontinuation of treatment before therapy has been completed. This was cited in Amanda A. Bembo and Paige L. Anderson in 2019. The negative impact of dropout in therapy is inevitable since the patient receives no benefit and may be discouraged from treatment seeking. And so until now, the research by Opris et al. In 2012 is the only one confronting the dropout ratio between the two types of therapy, concluding that there is no significant difference. Besides, according to Amanda A. Bembo and Paige L. Anderson in 2019, the study by Opris et al. In 2012 had some limitations since it doesn't estimate any index. Research shows that there are demographic and socioeconomic factors that are associated with an increased risk of dropout in adult therapy. It is possible that more factors specifically influence virtual reality exposure therapy variants, such as cyber sickness, as well as between session intervention, that is homework. In fact, this showed a significant reduction in abandonment, 17.1% compared to 25.2% in cases where it was not applied. Actually, attrition with RV has to be understood alongside its moderators. So that tells you that with virtual reality, the dropout rate in therapies reduce. So why won't you want to consider something like that? All right. In the case of in vivo therapy, it was shown it was revealed that most common reason for dropout was the fear of direct exposure to phobic stimulus, which is understandable because a person who has phobia, is scared that he or she is going to be exposed to certain things. And so again, a research by Amanda again and Page, they identified that the failure to properly immerse themselves in the VRET environment, as well as cyber sickness and vision complications, and discomfort in speaking with the therapist without being able to see it as the main reasons for dropout from VRET. In the case of in vivo therapy, it is revealed that the most common reason for dropout was the fear of direct exposure to phobic stimulus. It is favorable that in the case of being able to choose, more people would prefer virtual reality than in vivo exposure, and those who choose VRET are more likely to complete their treatment compared to those who had no choice of VRET. Previous research also suggests that given the possibility to choose, most patients will choose VRET compared to in vivo exposure. So let's look at basic concepts in VR. This is very important for us to understand how VR works, and that's going to take us to look at online virtual reality therapy. Now, the interesting thing is that it brings about some level of accelerated progression. Like we have said in previous slides, that people who choose virtual reality therapy actually find themselves completing their therapy sessions, right? Patients also are loyal to going through the entire process, and they get better results. And so if you're able to get better results with patients, and as a patient you're able to get better results, you definitely would want to stick to that. I personally have had the opportunity of using virtual reality in therapy sessions, and the interesting thing is, with the advent of Android phones, in which, or even cardboard system, in which the patient doesn't necessarily have to be with you for him or her to partake of the therapy sessions, it then makes it easy for a therapist to actually interact with his or her patient in another country or another part of the world without necessarily seeing each other. So the acceleration of therapeutic processes makes it easier and makes it more acceptable for patients to experience. The environment is more controlled. All that is needed is that the patient is either stationary at some point or moves around, or in a clear environment where there are no obstructions. And so the patient already knows that he or she has to pay attention and avoid all forms of distraction. And that's why the earphones or the headphones are attached to the VR headset, such that the patient is hearing whatever instruction the environment is passing across to him or her. No training in imagination is required. There is nothing like imagine yourself, because it is what it is. You are in that 3D environment, you can see. So let's take a case in point. A person who has a fear of public speaking, right? The VR environment creates an environment where you have to talk, and you are able to sense how you're feeling, right, when you're called to talk, because you have a phobia for public speaking. The feedback tool that is fixed to the fingertips helps to record how your body is responding to the feelings that you have at that particular point in time. And with time, begin to monitor the progression and begin to see the difference. So the situations are customized. Like I said, situations are customized. If it is certain phobia, you know, if it's height, if it is water, if it is animals, or maybe social anxiety, the virtual reality environment is already created for that particular purpose. And so the patient, right, finds himself or herself in that environment and is able to relate very well, because he or she doesn't have to imagine. He or she can see what exactly that environment looks like and how he or she feels. There is a sense of privacy a sense of privacy with virtual reality. You don't have to queue, you don't have to book appointment, as it were, to see a physician or to see a psychiatrist or a psychologist or a therapist. There is that privacy. You can be in your home, right, and experience this particular environment. All that you need is for you to connect with your therapist and have your headset or your Android phone, depending on what platform is compatible with your phone, and up you go. And that means that the therapist and the patient are able to share screens. They both see what is going on, they both know what is happening, and they both understand what they are working towards. So it's more or less like you're guiding your patient to go through a process that such a person is normally afraid of. And so I urge everyone watching this to pay attention to virtual reality. It's going to make your work easier as a practicing physician, or as a therapist or psychologist, or even a social worker. It's going to make your work easier because with different environments, you are able to navigate through the experience of your client, able to navigate through the experience of your patient and get the best out of them. It means that wherever you are, you necessarily do not have to move from one place to the other for your patient to actually experience this. So thank you for watching. You can reach out to me for further conversations. Thank you.
Hello. I'm happy to be a part of this conference, and I hope that it can draw close attention to the special circumstances of this year in our collective mental health history, and to that state of emergency that we find ourselves in. The unprecedented global response to the COVID pandemic changed our personal and professional lives, some changes barely reversible too. Humanity found itself at the crossroads, trying to decide which safety measures are here to stay, which ones would need to be dismantled as quickly as it is feasible. In making these decisions, we on the societal level need to re-examine function of certain features of our former lives, understand anthropological and psychophysiological factors, political aspects of the societal fabric, and to proceed accordingly. We mental health professionals play quite a role. This presentation discusses inter- and intra-personal effects of pandemic-related social distancing and isolation. We all went through it, right? Psychological implications of having survived COVID, of social deprivation, change in our previous socialization patterns, sensory considerations as they apply to different groups of population. We will talk about the near future and the after effects that may take years to mitigate. I think that polyvagal theory can come handy in understanding the immediate response of the nervous system to the orders of ceasing all interaction with others and staying indoors as much as possible, which means limited mobility. Polyvagal theory maintains that the mammalian social engagement system can downregulate our innate reactions to threat, which means if we are with others, we feel better and safer, whether the threat is tangible and observable or invisible or imaginable. When applied to the present day situation and the global response to COVID, we are dealing with a paradox. Instead of running to others, we need to fight to find the place to hide so we are safe. From the point of view of human evolution, opportunities to engage with others that have been the customary go-to in case of threat suddenly became recategorized as a threat in itself. This is the autonomous nervous system dilemma. However, as we retain our system and retrain our system to stay isolated indoors to avoid infection, we also find ourselves devoid of something else. We are devoid of qualia. The concept of qualia helps to comprise the list of items we seem to need to be anchored in the world, not to feel disconnected, lonely, desperate, having no purpose. Qualia are things that we can experience not vicariously, not through TV, not through the book, not through the hearsay, but in vivo. Things that we can smell, touch, eat, discrete sensory contents of life, that's it. Moving away from COVID into cyber hiding, when everything happens vicariously, seemed to be a plausible solution at the time. Yet digitized experiences range these days from shopping to teletherapy to online learning, which is great. But qualia seems to be a missing part of the experience. Peer interactions, accidental touches, proprioceptive input moving from point A to point B without fall, for example. And many, many others. To have an experience means to have qualia. And the qualia of an experience are what specifies that experience and makes it different from other experiences. In other words, we miss things that make our lives or used to make our lives unique. True qualia also implies that we experience any perception or sensation as organically interconnected with others in ways that continually shift with experiential context, thus further enriching the experience. Being put on the aesthetic, social, and sensory diet and having to adopt the life without qualia upset collective neurological balance and gave rise to new problems of social emotional functioning. Subjective sense of well-being would change as the pandemic progressed. The notion of normal has been rapidly dissolving in the throes of COVID-related adjustments. Many individuals responded to the pandemic and the impending doom of the virus with psychosomatic illnesses, some with symptoms that signified possible distortions in interoceptive abilities. Interoception is how we experience our bodies from inside, being able to localize visceral sensations such as temperature, intestinal pain from the gut, itch, nausea, and many more. Moreover, thinking, relationships, sense of self-worth, our memory, acuteness of our memory, short and long term, and the sense of purpose became affected as well. Vivid examples can be drawn from the statistics on domestic violence, child abuse, unemployment and underemployment, as well as anecdotal evidence of increased spousal discord and relationship breakups. We are yet to see the statistics on that. So how does it work? The Social Deprivation 101 course, the basic course. The limbic and sensory motor systems interact with direct and indirect circuits to determine what to do. That's our insightful behavior. And how to do it best. That's our motor behavior. However, in the lockdown conditions of the COVID emergency, we're supposed to shelter in place precisely when the limbic system gives off a command to flight. It paralyzes the social engagement system. I argue that consequences are dire. Loss of social aptness, minimized sensory input, and heightened anxiety that results in chronic, possibly chronic immobilization with fear. We know it from trauma research. Prior global history on trauma is the most important marker in emerging symptoms of anxiety and anticipatory anxiety. COVID-19 related lockdown necessitates close examination of existing mechanisms of trauma processing, as well as family and individual history of trauma and vicarious traumatization, to be routinely included in the process of assessment and addressed in psychotherapeutic treatment, regardless of the nature and scope of presenting problems. And I know that I mostly pose questions, but now we came to the gist of it, because we need to start with accurate assessment. And we have the diagnostic tools that start with chronic mourning, grief, loss, agoraphobia, to COVID stress syndrome. Somebody already proposed this diagnosis. It's not in the book yet, but it's making its way there. So let's look at the comorbidity. There is definitely a group of patients who love COVID. They come for help, yet they love COVID. Patients on autistic spectrum and just introverts are no longer exhausted by social interaction. They no longer have to deal with the uncertainty of physical aspects of behavior, of vestibular and proprioceptive behavior of others. They don't have to navigate spaces. They don't have to deal with the novel sensations. So individuals with deficits in neuromodulations, in those mechanisms that participate in predictive coding, neurobiologically feasible schemes for updating and refining neurosensory information from the outside world, report that virtual interaction is much more effective because they can concentrate on the cognitive and emotional aspect without constant anxiety about misinterpreting therapists' body movement, asking direct questions, and with the introduction of therapy in masks, they don't have to worry about the subtlety of the facial expressions. Well, that's also a very costly benefit. It's a very questionable benefit. But for example, an autistic patient shared that she could now anticipate emotional response. And then it opened up a new emotionally meaningful venue for her. And indeed, she was able to create new ties. She was able to initiate new online friendships. So lack of reliable social networks is a vulnerability and a cause of concern. So this is the concept. Because the patient cannot reliably survive without the actual relationships. And also, of course, the curiosity and creativity sometimes are in the dumps. I already talked about trauma, but I want to touch on it again because this is huge. And of course, the post-traumatic responses get reactivated. And we are dealing with the rapid explosion in the number of telehealth visits. It really transforms the healthcare delivery system. Patients re-experience symptoms, come back for treatment. And maybe some argue that returning to the mental health care face-to-face turns back the clock on innovation. However, providing care only in telehealth modality is probably not fully effective for those patients with the diagnosis of PTSD. This experience is true but elemental. It lacks composite qualities of multisensory interactions. All these signals, all these senses that we collectively call an office visit. Patients with history of generalized anxiety are also a group that require a lot of attention. Generalized anxiety is also activated via central sympathetic nervous system and proceeds to shape wrong beliefs, faulty thinking, and anxiety-dictated behavior. that can ultimately upset the equilibrium of the patient's life. Patients with OCD, with obsessive compulsive disorder, also need additional care. However, we see an interesting phenomenon here because COVID necessitates rituals that can coincide with the previously existing ones. So on one hand, we have the exacerbated symptoms of OCD. On the other hand, it can be a validation for the patient. Oh, I'm not that crazy. Yes, I need to wash my hands. We all need to wash our collective hands. So maybe it's possible that it's easier for the patient to address their rituals, because now rituals are basically validated and almost normalized. So let's talk about the eye-opening experience of telehealth that came to the rescue right away. So the positive is obvious that care can be provided immediately. We're quite there. We're very much there. We're there 24/7 almost. That's also the problem, because therapists are dealing with the burnout. They cannot they cannot make accurate assessment of patients' appearance for diagnostic purposes, especially obviously with the telephonic. It's quite difficult to engage younger children, harder to accurately assess gestural and body language because we just see the head. Some patients report difficulty in establishing privacy and confidentiality during psychotherapy, and those of you who've provided teletherapy know what it's like when the doors open and kids, cats, significant others, abusers sometimes walk in. So we may endanger inadvertently the patient. And obviously, of course, there are connectivity issues. So what do we have? What will stay? I'm sure that the teletherapy will stay, and it will help us with this quick, efficient response. But what can we do? How can we be therapeutic in the teletherapy situation? I included a couple of quotes. Some of them came from philosophers. But if you look at the beginning slides at the polyvagal theory, you will see how the philosophy and neuropsychology meet. We have our faces. And we can definitely extend their repertoire. What we can do, we can retune our nervous system to become more aware of facial expressions, vocal intonation, head gesture. And these will give us additional tools and additional ways of reactivating or activating neuron systems and having those neurons fire and having those relationships start and develop and stay. We also are dealing with other things other than teletherapy. We are dealing with the face-to-face therapy where we need to wear masks. So this widespread demand for mask wearing in public places limits our access to facial expressions. But as a balance, we get the proprioceptive and visual spatial input. For example, when you work with children and teenagers where both parties have to wear facial masks, it is crucial to take advantage of the gross and fine motor movement, tactile, and deploy all sorts of catch and throw games, pillow fight, race, and other pace-based games. This gives us additional tools for building the relationship. And of course, we can always rely on our emotions. And emotions are infectious. It's really important that we experience emotion, we show emotion, we name the emotion as needed. Because the only thing that can carry us through this crisis would be a quality relationship. And I'm leaving this short presentation with many, many questions for researchers, for practitioners, for myself. How can we restore and modify expectations of the basic mental health in the post-COVID world? How to be present in the technology assisted and other simulated environments and in other interventions that are not face-to-face. And most importantly, how do we remap the mental image of relationships? I believe that therapists and educators need to recycle the concept of resilience for the current situation of long-term isolation and develop new strategies. And hopefully we'll be able to apply them in all their on and offline professional encounters. I hope that this conversation will be continued. Be well, be safe. Thank you.
Доброго дня, мене звуть Коваль Олена Володимирівна, я консультант Міжнародного фонду відродження з питань доступності, знеболення та наркополітики. Хотіла б сьогодні вам повідомити про порядок обігу наркотичних засобів, психотропних речовин та прекурсорів у закладах охорони здоров'я. На сьогоднішній день будь-який заклад охорони здоров'я може працювати із застосуванням наступних двох схем. Перша схема – це коли заклад охорони здоров'я має ліцензію лише одну. На даному слайді ви бачите можливі схеми роботи закладів охорони здоров'я, які називаються аптечні. У першому випадку аптечний заклад отримав ліцензію на роздрібний продаж. При цьому він отримав право здійснювати продаж непідконтрольних лікарських засобів і видачу цих непідконтрольних лікарських засобів за рецептурними бланками форми F1. У другому випадку заклад охорони здоров'я, який є аптечним, взяв дві ліцензії. Перша ліцензія на роздрібний продаж лікарських засобів і друга ліцензія на здійснення діяльності, пов'язаної з обігом наркотичних засобів, психотропних речовин і прекурсорів. У такому випадку даний аптечний заклад може придбати, перевозити, зберігати, використовувати, знищувати, виробляти і продавати, відпускати всі лікарські засоби, у тому числі з вмістом наркотичних засобів, психотропних речовин і прекурсорів, і, відповідно, відпускати дані препарати за рецептурними бланками форми F1 і форми F3. Якщо ми говоримо про заклади охорони здоров'я, які здійснюють лікувально-профілактичні функції, то такі заклади теж можуть працювати або з одною, або з двома ліцензіями. У першому випадку, коли заклад охорони здоров'я отримає ліцензію виключно на медичну практику, єдиним інструментом для забезпечення пацієнтів лікарськими засобами залишається використання бланків форми F1 і F3. В другому випадку, коли заклад охорони здоров'я отримує ліцензію на медичну практику та ліцензію на діяльність, пов'язану з обігом наркотичних засобів, психотропних речовин та прекурсорів, заклад може придбати, зберігати, використовувати, знищувати лікарські засоби з вмістом наркотичних засобів, психотропних речовин і прекурсорів, а також виписувати всі лікарські засоби на рецептурних бланках форми F1 та форми F3. Якщо заклад охорони здоров'я здійснює діяльність, пов'язану з обігом наркотичних засобів, психотропних речовин і прекурсорів, керівники даного закладу повинні послуговуватися вимогами постанови Кабінету міністрів України номер 282, яка забезпечує ліцензійні умови провадження господарської діяльності з розроблення, виробництва, виготовлення, зберігання, перевезення, придбання, реалізації, відпуску, ввезення на територію України, вивезення з території України, використання і знищення наркотичних засобів, психотропних речовин і прекурсорів. Дана постанова, вона визначає вимоги, які повинні бути виконані для отримання додаткової ліцензії. А саме, в закладі охорони здоров'я керівник повинен своїм внутрішнім наказом визначити місця зберігання підконтрольних речовин. Для кожного такого місця повинно бути визначено обсяги збереження. Після того, як це визначено, місце збереження повинно бути облаштовано та обладнано відповідними засобами сигналізації. Наказом керівника закладу охорони здоров'я повинен бути складений перелік осіб, які будуть допущені до роботи з підконтрольними речовинами. Для кожної особи повинні бути прописані посадові інструкції, в яких чітко зазначено межі відповідальності такої посадової особи. В закладі повинен бути складений графік і проводитися щоквартальні інвентаризації наявності підконтрольних речовин. І, відповідно, заклад один раз на рік до Державної служби лікарських засобів та контролю за наркотиками, як органу ліцензування, повинен надавати звіт щодо кількості придбаних таких засобів підконтрольних, тих, які є в наявності, і ті, які були використані. Для отримання ліцензії заклад охорони здоров'я надає наступні документи: копію свідоцтва або посвідчення, або сертифіката спеціаліста, який підтверджує професійну придатність керівника закладу, довідку від нарколога про відсутність у працівників, які будуть допущені до роботи, протипоказів, які можуть свідчити про неможливість працювати з препаратами відповідної групи. Довідку Міністерства внутрішніх справ про те, що допущені до певної роботи працівники не мають судимостей, пов'язаних з вчиненням злочинів, які стосуються наркотичних засобів, психотропних речовин та прекурсорів. Дозвіл Національної поліції, який засвідчує, що визначені в наказі керівника об'єкти для збереження підконтрольних лікарських засобів відповідають певним критеріям. Копію документа, які визначають, чому даний заклад використовує дане приміщення, або це договір оренди, або це свідоцтво права власності для даного закладу, відомості про стан матеріально-технічної бази, наявності персоналу і відповідний опис, який перелічує, на скількох сторінках знаходяться ці документи. Що таке дозвіл Національної поліції і як його отримають? Впорядкування видачі дозволу здійснено постановою Кабінету міністрів номер 469. Дана постанова визначає, що працівники Національної поліції здійснюють перевірку визначених в наказі приміщень на їх відповідність певним архітектурним нормам. Зокрема, для кожного виду закладу охорони здоров'я, в залежності від обсягів зберігання, визначено, яка повинна бути товщина стін, яка повинна бути товщина стелі та підлоги, які додаткові заходи мають бути зроблені, якщо товщина ця є невідповідною, але цілком узагальнено, для того, щоб зберігати підконтрольні лікарські засоби, в закладі охорони здоров'я має бути окрема кімната виділена, яка обладнується сейфами або металевими шафами. Дані сейфи або шафи кріпляться до стіни або підлоги. Вхідні двері, вони обов'язково мають бути добре підігнані, або дерев'яні повнотілі з певною товщиною, або металеві, і мати не менше 2 замків, які врізаються і не є самозамикальними. Якщо в приміщенні є віконні отвори, то вони з внутрішнього боку або поміж рамами обладнуються металевими гратами. Якщо у вас є жалюзі металеві, які за міцністю не поступаються металевим гратам, то можна використовувати такі жалюзі. Додатково дані приміщення закладу охорони здоров'я повинні бути обладнані засобами сигналізації. Ці засоби вони повинні захищати будівельні конструкції периметру, віконні та дверні отвори на відкриття та розбиття, вентиляційні канали, теплові вводи і інші елементи приміщення, які доступні ззовні і можуть бути використані для проникнення. Ну, відповідно, приміщення повинно бути обладнано сигналізацією. В разі її спрацьовування сигнал тривоги повинен поступати на пульт централізованого спостереження суб'єкта охоронної діяльності. Як правило, це підрозділ МВС найближчий, який має можливість впродовж 4-5 хвилин бути на місці розташування об'єкта в разі, якщо є якісь інформація, що свідчить про злам даного об'єкту. Але ці загальні умови, вони стосуються таких приміщень, в яких можуть зберігати значні обсяги препаратів. Якщо керівник закладу охорони здоров'я визначає, що приміщення буде використовуватися для зберігання такої кількості препаратів, де загальна вага діючої речовини не буде перевищувати 10 грамів, або у приміщенні будуть знаходитися прекурсори сумарно не більше, ніж 15 кілограмів літрів, то в приміщенні достатньо встановити сейф, і на цей сейф встановити засіб автономної сигналізації, який є місцевим звуковим світловим сигналізатором. Тобто, коли відкриються дверцята сейфу, спрацює ліхтар і буде якийсь звуковий сигнал, ревун, наприклад, встановлений. Вимоги до приміщень визначаються наказом Міністерства внутрішніх справ України номер 52. Ще раз наголошую на тому, що спочатку керівникові необхідно визначити обсяги зберігання, тому що яке має бути приміщення і як його обладнувати, напряму залежить від обсягу збереження. Чим менше обсяги збереження, тим менше вимоги до приміщень. Після того, як зроблена ця робота, в закладі охорони здоров'я повинна бути утворена схема обігу лікарських засобів, до складу яких входять наркотичні засоби, психотропні речовини і прекурсори. На даному слайді ви можете побачити схематично, як це робиться на рівні наказу, хто за що відповідає, яка форма журналу має вестися у певному місці і яка має бути по обсягу потреба для забезпечення роботи закладу охорони здоров'я. Так, загальна кімната, яка називається місцем зберігання основного запасу, вона, згідно законодавства, може містити місячну потребу закладу охорони здоров'я. Як правило, в закладі охорони здоров'я за це відповідає головна медична сестра закладу, яка веде журнал, передбачений додатком номер 5 постанови Кабінету міністрів України номер 589. Тобто все, що поступає на місце зберігання основного запасу, обліковується саме в цій формі журналу. Все, що відпускається з цього місця, також обліковується в даній формі журналу. Якщо ми говоримо про заклад охорони здоров'я, в якому є декілька відділень, то, як правило, в кожному відділенні або у віддаленій якійсь будівлі робиться кімната зберігання. Обсяг збереження підконтрольних лікарських засобів складає 7-денну потребу даного відділення. Відповідальною за дане відділення є старша медична сестра, і вона веде журнал, передбачений наказом Міністерства охорони здоров'я номер 494. Журнал 6/О. До кожного журналу є інструкція про заповнення цього журналу, що в яку колонку пишеться, в які терміни і хто за це відповідає. В кожному відділенні може бути організовано декілька постів. На кожному посту, допущеною до роботи з препаратами наркотичних засобів, психотропних речовин і прекурсорів, буде постова медична сестра відповідальна. На посту у відділенні може зберігатися 7-денна потреба посту. Все, що зберігається на посту, відпускається з цього посту, обліковується постовою медичною сестрою в журналі 129-7О, теж передбачено наказом Міністерства охорони здоров'я номер 494. Виходячи з цієї схеми, ми з вами отримуємо фактично виключний перелік осіб, які будуть допущені до роботи з препаратами наркотичних засобів, психотропних речовин і прекурсорів у закладі охорони здоров'я. Це будуть постові медичні сестри, це будуть старші медичні сестри, це буде головна медична сестра закладу. З лікарського складу сюди будуть залучені, відповідно, головний лікар. Сюди будуть залучені ті лікарі, які працюють в умовах інтенсивної терапії реанімації, в операційних, а також в тих пунктах, де або приймаються особи, або їм надається невідкладна медична допомога. Це виключний перелік осіб, які можуть брати в руки препарати, можуть їх кудись нести, можуть якимось чином дозувати, можуть їх використовувати і, відповідно, залишки знищувати і списувати. В закладі охорони здоров'я може працювати багато лікарів, які будуть призначати препарати, слідкувати за тим, наскільки призначення відповідає потребі пацієнта, але вони ніколи в житті по своїй роботі не будуть стикатися безпосередньо з препаратами, тому до переліку допущених їх включати немає ніякого сенсу. Основна робота цих лікарів, вона заключається в тому, що вони заповнюють відповідну медичну документацію, обґрунтовують необхідність призначення препарату, змінюють дозування, переходять з одної форми на іншу, але безпосередньо з препаратами справи не мають. Якщо ми говоримо з вами про заклад охорони здоров'я, який є аптечний, то там також спрацьовує наступна схема. В закладі є місце основного запасу, і там може бути 3-місячна потреба закладу. Як правило, відповідальним за таке місце є або завідувач аптекою, або провізор, який веде журнал, передбачений наказом номер 494, форма 129-8О. В закладі охорони здоров'я типу аптечному може бути кімната для виготовлення, де може зберігатися не більше, ніж добової потреби, згідно того рецепту, по якому здійснюється виготовлення. Це може бути або кімната виготовлення, або асистентська. Це теж передбачено має бути наказом керівника закладу охорони здоров'я аптечного типу. Допущеними до кімнати виготовлення асистентської буде провізор-спеціаліст. І все, що він використовує, все, що у нього залишається, воно фіксується в прописах до виготовлення. В торгівельній залі ніколи не зберігаються препарати наркотичних засобів, психотропних речовин та прекурсорів, а також ніколи не присутні ті речовини, з яких виробляються такі препарати. В торгівельну залу за кожним рецептом фармацевт виносить ту кількість препарату, яка вказана в рецепті. І коли відпускає дані препарати, то вносить факт відпущення в реєстр відпущених препаратів. Тобто схеми фактично ідентичні, і з цих схем можна перелік допущених осіб чітко визначити по кожному закладу охорони здоров'я.
Доброго дня, Олена. Розкажіть, будь ласка, де ви працюєте і ким ви працюєте?
Доброго дня. Я працюю в благодійному фонді «Свої», який має мобільну службу паліативної допомоги. Я працюю психологом.
Яку саме допомогу ви надаєте цим пацієнтам?
Я надаю допомогу психологічну безпосередньо пацієнтам та їх родичам, пацієнтам, які перебувають вдома.
З чим частіше за все стикаються родичі таких пацієнтів? Які проблеми є у них, можливо, у спілкуванні або, можливо, які психологічні проблеми?
Першим, з чим стикаються родичі, чи вірно вони все роблять, чи правильно вони вчиняють до своїх рідних, чи надають вони правильну допомогу. Наступне питання, яке також дуже сильно турбує родичів, це після втрати близької людини почуття провини. Дуже часто родичі сильно переживають, що вони зробили щось не так, що вони могли набагато краще щось зробити для того, щоб подовжити життя близької людини.
Чи спілкуєтеся ви з родичами пацієнтів стосовно діагнозу пацієнта або стосовно того, що казати або не казати діагноз самому пацієнту?
Так, я також спілкуюся з цим питанням, але дуже часто виникає таке питання, що родичі і пацієнти вже знають про цей діагноз. Є деякі випадки, коли родичі намагаються притримувати і не казати правду, який діагноз має людина. Це дуже складне питання, тому що пацієнти завжди здогадуються, що з ними відбувається. І так стається, що інколи, ідучи на обстеження, пацієнту хтось із лікарів так чи інакше може сказати, що з ним відбувається. І це тоді стає дуже серйозною травмою для пацієнта, тому що він відчуває, що йому не довіряють, його обманюють, і це ж самі близькі люди. В моєму випадку навіть були такі випадки, коли пацієнт, коли дізнавався про те, який в нього діагноз насправді, він вирішував піти з життя самостійно. Це була ще більша травма в родині. По-перше, хвороба, а по-друге, те, що вони не сказали правду, що намагалися приховати правду, і це було дуже велике страждання для родини.
Як ви сама справляєтеся з цією нагрузкою? Це ж дуже важка робота, по факту.
Я також працюю з колегами, працюю з психологами для того, щоб проговорити ті речі, які мене турбують. І чому я також говорю, що всім родичам пацієнтів, або коли вони супроводжують своїх рідних, або коли вони вже втратили рідні, потрібна людина, з якою можна просто проговорити. Дуже часто родичі не хочуть говорити один з одним. Дуже часто це почуття провини, і коли є стороння людина, яка була не причетна безпосередньо до процесу догляду за хворим, родичі завжди тоді готові говорити, спокійно висловлюють, що насправді відбувається. Я ще дуже часто раджу про те, що якщо в родині щось таке сталося, обов'язково знайти близьку чи знайому людину, з якою можна поговорити, і робити це бажано навіть отак на природі, як ми зараз говоримо. Тому що під час ходьби відбувається навіть терапевтичний ефект. Просто зверніть на це увагу і дозволяйте дуже часто іти за своїми почуттями. Якщо вам хочеться кудись іти, то бажано іти, чути себе.
Які би 3 основні поради ви надали вашим колегам, які працюють з такими пацієнтами?
Перша порада – це кожна людина із нас, кожна людина унікальна. Дивитися безпосередньо на людину. З кожною людиною працювати окремо. Немає шаблонних питань, які можна зразу дати поради. Просто йдемо від людини. З кимось ми говоримо більш довше, а з кимось ми просто мовчимо, даємо можливості поплакати. Друга порада – обов'язково наполягати на тому, що розмова має бути, що це допомога, що ми допомагаємо. І бажано, щоб люди зверталися до нас за допомогою просто для того, щоб їм було що вони не одні в цьому світі, що хтось може просто послухати.
Дякую за запрошення до участі в такій важливій конференції. Сподіваюсь, що напрацювання будуть корисні в практиці забезпечення прав людей з ментальними розладами. Я, ознайомлюючи з діяльністю Національного превентивного механізму, хочу поділитися не лише, як відбувається моніторинг дотримання прав людини з ментальними розладами в стаціонарних установах України, але і ті проблеми, системні проблеми, які виявлені під час такого моніторингу і які, сподіваюсь, будуть вирішені завдяки спільним нашим зусиллям. З 2012 року на уповноважено покладені функції національного превентивного механізму і здійснюється моніторинг різних закладів, у тому числі закладів з надання психіатричної допомоги, закладів соціальної сфери, освіти, в яких перебувають особи з ментальними розладами. Останніх 3 роки до стратегічних напрямів діяльності повноважної якраз відноситься моніторинг закладів для осіб з психічними розладами. Протягом останніх 3 років Національний превентивний механізм здійснив 71 візит до закладів з надання психіатричної допомоги, саме стаціонарної. Це центри, ТВО, лікарні, психоневрологічні, психіатричні, психоневрологічні диспансери, яких на початок 2020 року нараховували 61. Крім того, ми відвідуємо стаціонарні відділення наркологічних диспансерів, яких на початок року нараховували 26. Які основні проблеми виявлені під час візитів, моніторингових візитів, і які здійснюються заходи? Слід сказати, що для забезпечення об'єктивності наші візити протягом останніх 7 років це візити без попередження спільно з громадськими моніторами та експертами. І за кожним таким візитом надсилається звіт до керівництва установи, керівництва безпосередніх органів виконавчої влади, яким підпорядковані такі заклади, а також відповідним міністерствам та відомствам. Крім того, системні проблеми висвічуються в щорічних доповідях уповноваженого прав людини і спеціальні доповіді за результатами діяльності Національного превентивного механізму. Останніми роками слід сказати, що дійсно відбулися зміни, у тому числі хочеться вірити, що і завдяки активній діяльності Національного превентивного механізму. Але водночас залишаються проблеми, Національний превентивний механізм продовжує виявляти недоліки діяльності закладів, що призводять до порушення прав людини. Діяльність Національного превентивного механізму здійснюється в межах Конвенції ООН проти катувань, нелюдського, жорстокого або такого, що принижує гідність, поводження або покарання. І головний фокус – це, звичайно, на недопущенні жорстокого поводження, катування та інших неналежних практик. Слід сказати, що на сьогодні, на жаль, існують системні проблеми щодо урегулювання фіксації тілесних ушкоджень під час перебування пацієнтів в закладах з надання стаціонарної психіатричної допомоги, а також процедури тілесного огляду. Це не відповідає вимогам Стамбульського протоколу, і відсутність такого чіткого нормування якраз створює підґрунтя для неналежного поводження з хворими під час перебування на стаціонарному лікуванні. Крім того, якщо і виявляються такі тілесні ушкодження, і про них навіть фіксується в стаціонарних картках медичного хворого, то про них не повідомляються органи поліції. Це теж велике порушення і може призводити до зловживань. Також на сьогодні треба сказати, що стандарти надання стаціонарної психіатричної допомоги потребують змін і чіткої регламентації і приведення їх у відповідність до міжнародних стандартів, до положень міжнародних документів. І відповідь на такі неодноразові рекомендації уповноваженого цьогорічний МОЗ нам дав, що ці стандарти передбачені в законі України про психіатричну допомогу. Так, там дуже є багато чітких норм, але разом з тим умови надання, вони не регламентовані. І якраз це приводить до того, що в різних закладах застосовується різна практика. Ну, зокрема, застаріла радянська ще практика, що всі відділення, кабінети, кімнати закриті на ключі вагонного типу, що палати пацієнтів без дверей, тому що так краще наблюдати персоналу, але разом з тим не забезпечується позитивне терапевтичне середовище, як того є в вимогах стандартів КЗК. Тому ми далі будемо наполягати, що унормування стандартів надання стаціонарної допомоги було чітко визначено і закріплено в нормативно-правовому акті. І тоді це буде точно буде сприяти його дотриманню. Одним з таких невеликих результатів діяльності національного превентивного механізму було наполеглива робота щодо такого нормування, застосування фізичного обмеження під час надання психіатричної допомоги. З 2012 року по 2016 неодноразові були рекомендації, тільки в 2016 році був виданий наказ МОЗ номер 240 від 24 березня. В цьому наказі передбачено, що фіксація здійснюється за допомогою, фізична фіксація здійснюється за допомогою ременів фіксації, однак тривалий час, майже 4 роки, таких сертифікованих ременів в Україні не було. Цьогорічні моніторингові візити свідчать про те, що заклади з надання психіатричної допомоги міста Києва, Тернополя вже придбали сертифіковані ремені фіксації і їх використовують. На жаль, в інших закладах ми спостерігаємо саморобні, а також застосування фізичного обмеження з порушенням вимог цього наказу. І, на жаль, це призводить до, іноді призводить навіть до травмувань пацієнтів. Ще однією з системних проблем, на які хотілося б зупинитися, це впровадження другого етапу медичної реформи з 1 квітня і ризики, які виникли з цим етапом. При всій необхідності реформування і підтримки реформування медичної сфери, слід сказати, що якраз уже півроку запровадження другого етапу виявило слабкі сторони і непрорахування всіх необхідних моментів. Зокрема, наприклад, надання психіатричної допомоги особам, які втратили соціальні зв'язки, яких, на жаль, майже в кожній лікарні, в кожному закладі з надання психіатричної допомоги виявляють під час моніторингу. Саме про цих людей не зовсім передбачено в реформі, яким чином і як це має бути зроблено для того, щоб не було порушено їх права. Крім того, ще є така категорія людей, які не можуть перебувати в психоневрологічних інтернатах за станом свого здоров'я, але і тривале перебування в закладах з надання психіатричної допомоги теж фактично реформа скасовує. Тому дуже треба чітко визначити, і це має бути дійсно спільна робота двох відомств, двох міністерств, Міністерства соціальної політики України і Міністерства охорони здоров'я, для того, щоб вирішити цю проблему на користь людей. Люди з ментальними розладами в закладах надання допомоги перебувають короткочасно тільки на той час, коли це потребують або лікування, або вирішення їх соціальних проблем. Водночас є установи, в яких люди фактично живуть пожиттєво. Це на сьогодні це заклади для осіб з психічними розладами, соціального захисту осіб, які страждають на психічні розлади. Це соціальна сфера, це дитячі будинки-інтернати, в яких фактично проживають не тільки діти до 18 років, але і в молодіжних відділеннях підопічні до 35 років. Їх на початок року було 61. Це психоневрологічні інтернати, 145 таких інтернатів. І це ми віднесли до цієї сфери, правда, це тимчасового перебування, приватні реабілітаційні центри для осіб з хімічною та поведінковою залежністю. На жаль, їх кількість невідома, і про це буде говоритися далі. Саме відвідування цих центрів цього року вперше стало такою системою і пріоритетом. Вони теж в плані виконання стратегічних напрямів діяльності уповноважена саме передбачена приватні реабілітаційні центри. І їх на початок цього місяця вже відвідано 26, і відвідування продовжується до кінця року. І виявляються проблеми з дотриманням прав людини. Які ж основні недоліки, які основні проблеми виявлені під час візитів до закладів соціального захисту осіб, які страждають на психічні розлади? Хочеться сказати, що за 8 років нашої діяльності дійсно відбулися значні зміни. Міністерством соціальної політики врегульовані дуже багато питань, які були унормовані в сфері діяльності цих установ, які раніше призводили до дуже значних порушень. Це і нормування використання 25% пенсії чи соціальної допомоги осіб, які перебувають в цих закладах. Це і регламентація діяльності з надання трудотерапії та інше. В багатьох закладах змінюється відношення. Це саме головне, на що звертає увагу Національний превентивний механізм, це ставлення персоналу до підопічних, до вихованців. Це має ставлення буде поважливе, як з дотриманням людської гідності. Але, на жаль, слід сказати, що цьогорічні візити виявляють продовження застосування негативних практик і виявляють системні проблеми. Що призводить до, ми можемо сказати, що, на жаль, і зараз існування таких великих, особливо великих закладів, таких як Святошинський психоневрологічний інтернат, де проживають понад 700 жінок, Покровський психоневрологічний інтернат для 500 чоловіків. Це інтернати великі, вони потужні, у них потужна матеріальна база, але водночас врахувати інтереси кожного окремого, індивідуальні потреби кожного підопічного в таких інтернатах дуже важко. І навіть те, що я прозвучала, що один інтернат для жінок, а другий інтернат для чоловіків, продовження існування окремих установ окремо для чоловіків, для жінок. Це є дискримінація, і це є стигматизація цих людей. І, на жаль, тільки окремі області за цей час, наприклад, така як Запорізька, якраз врахували рекомендацію уповноваженого і роблять кроки для того, щоб змінилася формат існування цих інтернатів. Звичайно, що ми не тільки проти великих інтернатів, ми можемо сказати, що інтернатна система сама, вона конче потребує зміни. А зміна буде тоді, коли будуть створені альтернативні послуги в громадах. Але на сьогодні, поки існують інтернати, ми маємо дбати про те, щоб максимально комфортно, максимально забезпечити права людини в цих інтернатах. Ще одна така проблема нагальна. Якщо в закладах надання психіатричної допомоги системи охорони здоров'я саме на наполягання за наполегливими рекомендаціями уповноваженого в межах реалізації національного превентивного механізму були прийняті в 2016 році 970 наказ МОЗ, де були спеціальні затверджені форми усвідомленої згоди на лікування в психіатричних закладах, то проблема лікування в установах соціальної сфери осіб з психічними розладами до цього часу залишається під знаком питання. Тому що люди перебувають добровільно в закладах, але згоду на лікування, яке їм там призначається і надається, як правило, це підтримане лікування, ця проблема не врегульована. З метою того, щоб не було ніяких зловживань, і якраз лікарі в психоневрологічних інтернатах і ставлять це питання, і вони самі порушують це питання, що ми ж даємо і у разі необхідності, і для того, щоб запобігти якихось спалахів захворювання, загострення захворювання, іноді потребують і ін'єкційного лікування, але ж згоду на таке лікування підопічні вихованці не надають. Тому ця проблема також потребує, на наш розсуд, врегулювання і з метою забезпечення прав вихованців та підопічних. Я вже говорила про моніторинг реабілітаційних центрів, в тому числі, здебільшого, це приватні центри для осіб з залежностями. І такі візити здійснюються без попередження. Такі візити, на жаль, дуже важко проходять, тому що власники, приватні власники, як правило, розташовують такі заклади в приватних приміщеннях, і допуск моніторингових груп не завжди відбувається дуже чітко. Для здійснення моніторингового візиту іноді приходиться і викликати поліцію для того, щоб можна було приступити до роботи. Які самі головні проблеми? Якраз саме головна проблема те, що надання послуг з реабілітації відбувається на порушення Закону України про соціальні послуги, який вимагає того, щоб всі такі центри були в реєстрі надавачів соціальних послуг. На жаль, можемо констатувати, що таких закладів в реєстрі на кінець вересня було всього 11, що ми подивилися, саме приватних, і то це здебільшого було надання послуг для осіб похилого віку. Відсутність в реєстрі надавачів спеціальних послуг цих центрів якраз і унеможливлює здійснення їх контролю за їх діяльністю, їх моніторингу. Крім того, як з'ясовується під час візитів, на жаль, часто клієнти цих центрів говорять про те, що їм надається медична послуга, але ці послуги надаються всупереч законодавству, без ліцензій на провадження господарської діяльності з медичної практики або відповідних договорів. Також одним з таких типових порушень це примусове утримання клієнтів в реабілітаційних центрах. Навіть там, де вони поступали добровільно на реабілітацію, але коли це реабілітаційні послуги затягуються на місяць-два і більше, вони намагаються і мають бажання, виявляють бажання залишити центри, але закриті двері, закриті ворота, закрита територія і відсутність дозволу фактично перетворює їх в утриманців і без власної волі, що є порушенням статті 146 Кримінального кодексу України. І, на жаль, такі факти виявляються під час візитів. Крім того, ще одна така важлива проблема – це відсутність центрів для реабілітації дітей. Відповідно до закону про психіатричну допомогу, надання психіатричної допомоги, а в даному випадку це психіатрична допомога у вигляді реабілітаційних послуг, вона для дітей і дорослих має бути окремою. Через відсутність центрів, окремих спеціалізованих центрів для дітей, виявляється під час візитів, коли діти перебувають спільно, підлітки спільно з дорослими особами, і крім того, відсутнє ще і окремий поділ центрів за видами залежності, алкогольна, наркотична, ігрова і так далі, що якраз сприяє поширенню негативного досвіду серед клієнтів. Сама реабілітація відбувається не завжди фахівцями, не завжди кваліфікована і, на жаль, іноді можемо констатувати, що це просто тимчасове тримання людей, обмеження їх волі з метою недопущення їх до якихось друзів, як правило, це оплачують рідні. Зрозуміло, що це величезна проблема для сім'ї, але без власної згоди, як перебування в таких заходах, це вже є обмеження, незаконне обмеження волі. Ці окреслені проблеми – це тільки деякі самі нагальні на сьогодні, але про них можна говорити більше, і я сподіваюся, що саме наша конференція дасть змогу висвітлити самі нагальні, самі такі проблеми, які потрібно вирішити спільними зусиллями. Ми зможемо їх розв'язати і саме для того, щоб забезпечити якнайкраще права людей з ментальними розладами.
Hello, let me introduce myself. My name is Larisa Bakhmutova, and I'm researcher of National Antarctic Scientific Center, Ministry of Education and Science of Ukraine. I'd like to present you some information or interesting fact about peculiarities of self-efficacy of Ukrainian Antarctic expeditions participants. I'd like to give you some background information about the Ukrainian Antarctic Academic Vernadsky Station. It's located on Galina Island in West Antarctica. We can see it on the map. Human life in Antarctica is a dynamic process that takes place with the changes in the functional system of the organism due to effects of environmental factors. Well known that the long stay in extreme natural conditions leads to psychophysiological changes. This is characterized by psychophysiological and psycho-emotional instability such as reduced performance, grumps and depressions, low activity. This may lead to self-isolation and formation of microgroups, which affects both to health and personalities' interaction in isolated group. This leads to transformation not only of human health, but also of the psychophysiological state. We can see it on the diagram, which shows the Antarctic syndrome in the winter's team members during the year. We can see bad dream and bad mood in August, September and October. Monitoring of psychophysiological and psychological indexes is an important part of assessing the condition of winterers in extreme conditions of Antarctica. We try to study the dynamics of self-conception of the psychophysiological state of winterers during the period of adaptation and polar night. Of the basis of the express method of the scaled self-assessment of psychophysiological state, the monthly monitoring the condition of winterers of Ukrainian Antarctic Academic Vernadsky Station have been carried out. People have been isolated from the other world during 12-13 months. The assessment of psychophysiological state is based on the following indicators: well-being, activity, mood, efficiency, health status. The task of the program is formation of psychophysiological background of potential winterers to live in Antarctica. The basis of the program are formation of unit team taking into account personal features and social skills of candidates, optimization of interpersonal interaction of future team members, psychophysiological support of members during the winter. On this picture, you can see the polar station during the polar night. It's not easy to state for this winter in condition. Our study consists of 3 stages. Training of people in conditions of isolated group close to polar specific. Arrival to the station and adaptation to the extreme conditions of Antarctica. The period of polar winter with a long polar night and absence of the sun. Taking into account a limited number of people, we proclaim the statistical significance. The indexes of own self-determination of the psychophysiological state during 6 months are presented. As we see, April and June are the most positive months. So, we can see here the indicators of psychophysiological state of winterers. The next picture shows the psychophysiological indicators. The self-assessment indicators were monitored by emotional state, interpersonal relationships, collective and personal efficiency. These data are present on the picture. The dynamics of the self-assessment
indicators of the condition of winterers. So, we'd like to state that the analysis of the dynamics of the self-assessment indicators of interest during the period of acute adaptation and polar night show the psychophysiological state level have been stabilized higher due to interpersonal psychophysiological indicators. This topic is very interesting and important for us. That's why we have prospects for future researchers. In this year, 10 people take part in 25 Ukrainian winterers Antarctic expeditions, and we provide the monitoring of the psychophysiological state as well. Thank you for attention.
Okay, so just to briefly address the COVID disruption. So firstly, this research began in partnership with the Mental Health Trust. Due to the impact of the pandemic, this broke down, and at short notice, we recruited external experts through personal contacts. As many healthcare professionals were busy working on the front line, we were unable to recruit key members of the MDT, such as nurses or bed managers, so issues uncovered during the research may not have been representative of the whole MDT. Secondly, the circumstances affected the team itself, as a newly formed mix of internal and external students. And being unable to meet or bond in person, it may have taken longer to gel cohesively. Finally, on a personal level, we have all moved home since the college closed, apart from Jiakun, who was volunteering on COVID wards, and Paulina, whose family lives abroad. I myself came down with COVID symptoms mid-March, and the recovery was slow, spanning over a month. My contribution to the team at this time was compromised, and although everyone was very supportive, I'm very aware of the extra strain on the project.
So, thank you for joining us today. We're going to tell you about our project that is AI in Patient Flow, Applications of Artificial Intelligence to Improve Patient Flow in NHS Acute Mental Health Inpatient Units. My name is Jack, and I'm joined by Jiakun, Paulina, Fatema, Joe, and Iain. So, just to give you an overview of what we're going to talk about, we're going to introduce the project, go through our aims, method, what we did, our results, and what we came up with. So, where did the project come from? So it was first commissioned by Dr. Jo Emmanuel, who is Clinical Director for CNWL Mental Health Trust. She told us that on the trust, they were experiencing problems in their patient flow, and she was interested to see how AI could be used to help solve this. So what is patient flow? NHS Improvement defines patient flow as the ability of a healthcare system to manage patients effectively and with minimal delays as they move through the stages of care.
And what is AI? AI describes a set of advanced technologies to enable machines to do highly complex tasks, often described as machines having human-like capabilities, such as problem-solving, decision-making, and object recognition. There is, however, no standard definition of intelligence and no single agreed definition of AI. In addition, the line between AI and other techniques, such as big data analytics, can be blurred. In this project, we are mainly focused on AI as machine learning and natural language processing.
Inefficient patient flow. Inefficient, poor patient flow means that patients do not move through stages of care effectively and experience delays when they're not receiving good quality of care. The consequences of this are as follows. Demand exceeds capacity and queues are formed, leading to overcrowding, stressful and unsafe environments. Patient individuals' needs are not met, leading to worse clinical outcomes and increased readmission. Staff are overstretched, stressed, and prone to making errors. Inpatients are moved between wards, making it difficult to manage patients and deliver care. Length of stay in hospital increases, which are shown to have an impact deterioration in frail patients.
And why can we use AI to solve this problem? First, medical data has been increasing in volume and complexity, which exceeds the capabilities of the current systems and professionals to extract all information in a meaningful way. Secondly, as we learn in MHCO, technological shift is a part of NHS vision, outlined in the long-term plan, the Topol Review, and others. NHS recognizes that technology will play a crucial role in delivering high-quality care in response to financial pressures. Institutions like NHSX and NHS AI Lab are working to use AI to deliver NHS goals. Thirdly, the possibilities for data-driven solutions in mental health are much broader than currently existing patient-facing apps. There are opportunities to advance understanding of mental illness, improve detection and diagnosis, develop risk-based approaches, and importantly, help redesign services around the needs of patients, such as patient flows. The need for improved patient flow and mental health units is identified in literature. Similarly, research investigated the use of AI in mental health or patient flows, mainly in emergency departments. However, little research has been done to bridge those areas, which shows an untapped potential.
Aims. So our main aim for the project was to investigate the potential of AI to improve patient flow in acute mental health inpatient units, devise a theoretical model showing the use of AI in these units, and formulate recommendations based on these. To achieve this aim, we devised 3 primary objectives. 1. Construct a model showing the overview of patient flow. 2. Identify issues that lie within patient flow. And 3. Establish which AI solutions can be implemented in these wards. Based on our model of patient flow and understanding of the issues and solutions, we ultimately aim to develop recommendations for trusts regarding AI integration.
Our method involved 6 steps. Before conducting interviews, we did a narrative literature review to give us a background knowledge on the topic. This acted as a guide when devising our interview questions. We carried out a total of 21 semi-structured interviews, which were transcribed, coded, and analysed using thematic analysis. Synthesis and discussion of results followed, and finally, we developed a model and a set of recommendations for the use of AI in mental health inpatient units, which were validated by an external consultant.
For the mental health literature review, we found 3 recurring themes. The first 2 were factors affecting length of stay and factors affecting readmission risk. These were split into patient factors such as demographic and clinical factors, and then there were service factors around the care delivery and how patients experience this. The final theme was predictive factors. Interestingly, most of the factors linked retrospectively were found not to be significant prospectively.
As you can see, AI in psychiatry can be divided into 3 areas of focus: diagnosis, prognosis, and treatment. Studies have shown that AI can be used to improve risk prediction accuracy, create effective triage systems, and identify novel disease biomarkers. Next, we looked at the use of AI in improving patient flow. AI was used to identify factors associated with long length of stay, complex care, and high risk of readmissions. We can then predict operational needs based on these factors to optimize resource allocation. In summary, AI can be used to improve clinical outcomes, optimize resource allocation, and result in improvement of patient flow.
The mental health interviews data were extrapolated into 6 themes. Of this, problems were identified with measuring patient flow. For example, length of stay was identified as an unsuitable metric as it does not consider patient mix and certain conditions can skew national benchmarks. Interviewees suggested a better measurement would be delayed transfer of care. Problems with inpatient systems and services were also identified. In this, staff shortages were identified as a main barrier to treatment, leading to increased waiting times, reduced continuity of care, and adverse decision-making. Lack of funding has impacted both inpatient and community care systems, resulting in inappropriate skill mix, premature discharge, substance misuse, non-adherence, family inability to cope, and subsequent readmission. In inpatients, there is a severe shortage of beds. Whilst in the community, it can take up to 6 weeks to assign a social worker to a case, resulting in delayed transfer of care. In terms of record keeping, EHR had a mixed review. However, a lack of integration was consistently reported as a barrier to sharing information. In addition, it was also found that doctors fail to read notes, do not have access to them when appropriate, and fail to take thorough enough records. Problems with clinical management, it was reported that predictions to medication response were poor, resulting in a system of trial and error, which extends length of stay.
For the AI results, we identified 5 themes during our thematic analysis. Data from interviews placed great emphasis on the need for large, clean data sets. EHR was highlighted as a good source of data, however, its main issue is that it's very unstructured. Interviewees offered multiple solutions, including predictive solutions related to patient and back-end, automation of tasks, diagnosis, therapy, and monitoring solutions. The implementation of AI would create value for 4 stakeholders: clinicians, patients, trusts, and the NHS as a whole. Interviewees emphasized the importance that AI should be created as an assistive rather than decisive tool. AI solutions need to be accessible and user-friendly to encourage the uptakes by healthcare professionals. Additionally, AI could prevent avoidable mistakes from occurring due to human error and can also free up doctors' time from doing admin work. For the challenges of AI models are far from being perfect, and interviewers pointed out 3 major challenges that AI models face: technical, regulatory, and humanistic. AI models can be very inaccurate and often need support infrastructure that the NHS lacks.
So we collated all of the information that we gathered and made a diagram showing the patient flow model from our understanding. In order to help explain this further, we're going to introduce you to Jenny. She is a patient who's receiving a chronic psychiatric patient who's at home and receiving patient monitoring and care in community. Yesterday, she deteriorated and called her local crisis team. They assessed her in community and admitted her to the inpatient ward. She was then assessed before receiving intervention and monitoring, and when she is medically optimized, she will then be discharged back into the community.
In our discussion, we grouped problems and solutions together. We identified three areas where AI can help. These included clinical decision support, community monitoring, and operational efficiency. 1. Inpatient clinical issues happen throughout flow. They include slow and inaccurate decision-making and an inability to target interventions to patient needs. Although most issues are interconnected, there are 3 main steps which were identified as crucial for patient flow.
When looking at this, assessment was the first thing that came to mind. Patients may present with the same condition or even the same symptoms, but their risk will differ significantly based on their combination of personal factors. The current system has a method to group patients into red, amber, and green. However, it's limited to a clinician's judgment, which often leads to admitting patients who don't necessarily need admission. AI can be used to risk stratify patients based on their personal factors. AI triage models could not only suggest the right interventions, but also the right sequence of them. Patients who are at low risk can either be directed to other services or community and self-care treatments, thus saving resources. Patients at higher risk can be streamlined straight to interventions. Depending on the patient, diagnosis can also be part of their assessment. Misdiagnosis is a commonly reported issue on mental health wards. Assessments are often slow, subjective, uncertain, and vary between clinicians. These all lead to poor outcomes for patients. According to the research and experts, in the future, AI could be used to analyze complex behavior patterns, neuroimaging data, or blood samples to find biomarkers for mental health and enhance our understanding of underlying mechanisms of mental health. AI algorithms with superior diagnostic accuracy to clinicians could reduce the variability and the quality of decision-making.
2. So the next area which impacts patient flow is interventions. The current process of finding the right medication is trial and error against best practices, with interviewees agreeing that this lengthens stay. Medications are often ineffective and produce side effects which can demotivate patients. Interviewees and research both suggest that AI can be used to predict a patient's response to treatment, improve medication adherence, support clinician treatment decision, and track patient recovery. This all has the potential to improve patient flow, and in the future, a combination of data from different sources may be analyzed by AI, enabling medications to be personalized.
The last step in patient journey is discharge. Many patients are either discharged too early, which leads to readmission, or stay on wards despite being medically optimized. To ensure smooth flow, discharge needs to be planned from the very first day of admission, which is currently not always possible. Our findings suggest that AI could support timely discharge. Clinical decision support systems are programs that deliver recommendations based on patient data, guidelines, and the newest scientific evidence. Those systems include AI-based prognostics, which are then presented to clinicians in the form of real-time dashboards. The system can also suggest a possible or required next step in the care process, such as send a plan to the GP or organize a care package. With additional support, clinicians with less experience, such as junior doctors, could make decisions faster and deliver appropriate care, possibly reducing the current culture of risk aversion.
Initially, we thought that community and social care would be beyond the scope of the project, but our findings indicated that they are essential to ensuring smooth patient flow. And although funding ultimately underpins issues with social services and supportive accommodation, technology could certainly bridge the gap between community and mental health units. A novel approach widely discussed by interviewees was digital phenotyping, which offers a way to collect longitudinal data from digital services and wearables. Mental health fluctuates over time, and can be affected by many environmental factors. Digital phenotyping could help us understand mental health better by analysing a range of behavioural and physiological measurements. This data could then be used to improve clinical decision-making and prevent relapse by delivering early intervention, ultimately reducing the demand on mental health inpatient units. Interviewees believe that this prevention and more community focus will be the best way to combat inefficient patient care.
Finally, the last group of problems and solutions are related to hospital management. There are operational challenges found within patient flow in mental health wards that ultimately affect staff, quality of care delivered, and inadvertently patients. There are three main aspects which have a critical influence on patient flow. Firstly, patient records. Trusts are already using electronic health records, but often have missing data fields and suffer from usability issues. Patient information is typed into electronic health records by clinicians in a process that often lasts longer than the interaction with the patient itself, leading to high variability and errors in notes. Natural language processing could help with information extraction, clinical coding, and dictation. It can be used to understand the sentiment of text and summarize consultations automatically.
With regards to operational efficiency, the next step was resource allocation. Increasing demand has been causing pressure on mental health wards, and interviewees raised an issue of not having a bed free for patients in need. Ideally, capacity and demand are in perfect.
Finally, automation included in workflows. So design of the system and workflow has a huge impact on the quality of care and patient flow. Interviewers reported that current workflows cause problems with clinical management, such as wrong patients being admitted, prolonged referrals, and assessments. This creates a cycle of inefficiency. With time, care pathways will need to be redesigned around new technological capabilities, and some administrative roles will be automated and low work value, such as typing, will be substituted for NLP.
We then collated all this and mapped it on to show a flow model with the AI integration. With all these solutions applicable to the patient flow structure, it will help improve the patient flow, and Jenny will now be able to receive the right treatment in the right place at the right time.
So as with any tech solution, there are limitations. In this case, challenges around data access, cultural acceptance, regulation and governance all pose major hurdles. With data particularly, for accurate AI algorithms, a large amount of high-quality data is needed to learn from and prevent biases. Informed consent is required to use a patient's data, which will likely limit completeness of data sets. And question marks also remain over safeguarding those with compromised mental capacity and sharing of EHR records, EHR to entrust. AI implementations may impact the roles and skills of the NHS workforce, both potentially threatening existing ones and demanding new ones. Training and education needs to accompany changes ensuring receptiveness and end usability, and thought must be invested in how to best prepare staff for this changing landscape. Interviewees also highlighted the difficulty of actually validating AI models in healthcare for scalability. And as training clinicians, we understand that thoroughly testing any system relevant to patient care is of the utmost importance.
As learned in our Sustainable Business module, Edward Freeman's stakeholder theory states that it is important to address all stakeholders involved when proposing recommendations. Our recommendations were based on this matrix outlined in the slide. However, due to time and resource constraints faced during this research, it was unrealistic to contact large NHS bodies, thus we only engaged with healthcare professionals and AI experts.
Since we are unable to address all stakeholders involved and get their input and advice, we consulted an external consultant to review our recommendations and model to ensure its feasibility. Our recommendations are targeted to mental health trusts eager to adopt AI solutions, such as CNWL, amongst other tech champions. In the near future, these are implementations that can be achieved without significant hurdles. Prioritize operational efficiency solutions, such as automation of admin jobs with NLP to extract value from the existing systems and reduce costs. Implement a risk stratification and real-time data analytics to help with discharge, triage, and managerial resource allocation. Thirdly, engage users and stakeholders early. Consult representatives of clinicians, mental health inpatient trust managers, and patients to ensure their concerns are addressed and solutions are user-friendly.
These implementations, the following need to be ensured. Firstly, that solutions are designed specific to existing problems rather than mapping solutions onto problems after development. Secondly, considering solutions that come from private or public providers, but ensuring they adhere to the available regulatory, ethical and quality guidelines such as Consort, NHSX, MHRA, NICE. Thirdly, engage with data sharing initiatives which allow for collaboration between trusts and increase diffusion of technology.
Our future recommendations are of high potential, but there are challenges that prevent implementing them anytime soon. Once more research is done in this area, consider digital phenotyping as a possibility for community patient monitoring. Secondly, trusts can encourage the rollout and engagement of clinicians with technological training to increase technological literacy. And finally, trusts should consider development of new roles, such as clinical information officers.
Now, there are two major limitations of our research. We carried out a narrative literature review, which can present with selection bias. And since the narrative literature review shaped our interview questions, it could also have impacted our study. Secondly, a lack of quantitative data didn't allow us to triangulate our results. A mixed method of both qualitative and quantitative analyses will reduce the limitations of our study and further ensure the validity and credibility of our research.
So in the future, we hope to discuss running a case study with a mental health trust that is interested in the potential use of AI, such as CNWL. We would gather information on their trust-specific issues and tailor AI recommendations to match their exact needs. AI algorithms are costly to develop, but are cheap to run up and scale. As we learned in our health economics module, healthcare is a finite good, and conducting a cost-effectiveness analysis is important to ensure the benefits derived from AI are not too costly.
The module studied this year have provided invaluable knowledge that we were able to apply to this project, especially our managing healthcare organisations, healthcare informatics and health economics modules. We have had such an enjoyable yet stressful 3 weeks finalising our project. We made some new memories and gained some new technological skills. Here are some of the highlights of our last few weeks. Looking back, this is what we've covered today. We talked to you about why our project came from, why it was important, our aims and objectives, what we did, what our results showed, and what we recommended trusts should do next. Thank you for listening to our presentation, and we welcome any questions.
Okay, I think I lost my internet for a second there, so I'm not 100% sure. I will stop this recording and I double check and I'll start a new one in the meantime, okay?
Okay.
Good afternoon, ladies and gentlemen. My name is Olena Koval and I'm an assistant professor of global mental health at Asina Institute, Vrije Universiteit Amsterdam. Today, I would like to talk to you very shortly about the research that me and my team have been conducting for the past 5 years, and that is the research into orthorexia nervosa. You may be wondering what orthorexia nervosa even is. Well, this is a new disordered eating pattern that has been going around the social media and the news quite a lot. And the main characteristics of this eating pattern is obsession with the quality of food. So the individuals progressively develop obsessive and compulsive thoughts about the types of food they are consuming, but not about the quantities, but more the quality. So are they healthy, and what kinds of foods should be cut out of the diet in order to, for instance, prevent cancer or contribute to, in general, what is called healthy lifestyle. It is important to note, as I already said, that weight loss and the appearances are not the primary goal of this disordered eating pattern. It is more about trying to get the best quality of food in order to lead healthy lifestyle and prevent variety of medical conditions in the future. It sounds like a very good thing, right? Eating healthy is something that everybody strives towards. However, in the people who are suffering from orthorexia nervosa, what is observed is that they are progressively cutting out groups of foods that are considered to be unhealthy, which can lead to quite detrimental effects on their health, both physical and mental. Important to note that this disorder is a really very new phenomenon, first mentioned in 1997, as I will mention later on, but what you can see is there were barely any publications in the early 2000s on the topic. Right now, the increase is exponential, with approximation of 70 to 80 papers published in 2020 alone. So where does it originate from? It originates back in the 90s when Stephen Bratman noted this pattern among the yoga students and the fitness people. And as a clinical entity, orthorexia nervosa was not manifested until 2004-2005, when it actually became more and more widely spread as a phenomenon that people talk about. And today there are many scientific studies that discuss orthorexia nervosa, and one of the major questions that everybody is talking about is whether it should be in the official classifications of DSM and ICD. So as we saw on the graph before, there are a lot of scientific studies published annually on the topic. But what do they talk about? Well, if you really go on PubMed or Google Scholar and you try to search for papers on orthorexia nervosa, a vast majority of the papers actually talk about the possibility of the prevalence of this disordered eating patterns in different populations. For instance, in Italian university students, or in Turkish nutritionists, or the sportsmen in northern Italy, and so on and so forth. But what we noticed is also that while the research talks a lot about the prevalence and the possible diagnostic criteria and sensitivity and specificity of these diagnostic criteria, orthorexia also went online. It went into the social media, in the general media culture, and what we see is that it got a life of its own. There are so many articles in major online media journals, and also on a lot of social media websites, about what are the symptoms of orthorexia, who are orthorexic, people suffering from orthorexia, how it can be treated, and so on and so forth. And what is very important to know, that a lot of these articles on social media and other media outlets are not really based on the scientific publications. It's more that people developed an understanding of the disorder, and the whole disorder got a life of its own on social media. So we noticed this disconnect between the scientific and the social, and we would like to, the goal of our team is to bring this societal perspective to research, and to bring research into the society, to give voice to the people who are self-identifying as having orthorexic tendency, to give voice all to people who have family members or relatives, or maybe the health professionals that have been treating individuals having orthorexic symptoms, and also to look at what is this phenomenon and how did it develop on the social media in the past years. So very shortly, I will present some snapshots of a variety of studies that we have done in the past 5 years. So we started with actually asking health professionals, what do they believe orthorexia nervosa is, and how it should be addressed. So in the Netherlands, most of the studies that we have been conducting were within the Netherlands, but 95.6% of health professionals that we reviewed believe that orthorexia is prevalent in the Netherlands. To the what degree varied, but at least they recognized it as something that exists in the country. Also, 63% believe to have assisted the patients, the clients who fulfilled criteria for this disorder. Also, quite a lot of health professionals in the Netherlands believe that orthorexia should be a part of DSM-5, DSM-6. Also, we investigated what could be the roots of this disorder, and we identified that individualism, perfectionism, and performance-oriented culture seems to be closely related to the occurrence of this disorder. And what we also discovered is that there is such a factor as desire of being in control of your own life, because you cannot really control the weather, or you cannot really control economic crisis or corona. However, what you can control quite easily is what kind of foods you're putting in your mouth and what kind of foods you're consuming. And that seems to be quite a prevalent and quite a big driver for the development of this disordered eating pattern. We also know that that orthorexia, as majority of mental health disorders, doesn't appear overnight. It's not like you go to sleep as a healthy individual and you wake up with orthorexic tendencies. There are quite a lot of predisposing factors that we identified. These are the studies that were done asking the health professionals regarding their experiences and their experiences of treatment of people with orthorexia. So you can see here that there are quite a lot of predisposing factors that health professionals believe to exist. Some of them are more personality linked, some of them are more biological, for instance, biological age. Other ones are more societal. And there are always some triggers. It also does not appear and doesn't develop on its own. Quite a lot of individuals are believed to have difficulties in social life or certain social stressors that are triggering the development of orthorexia. Another very big aspect was the use of social media, which I will be discussing shortly during my talk today. Symptoms of orthorexia nervosa vary in people. However, in general, despite the fact that official definition of orthorexia says that there is no link between the weight loss, desire of weight loss, and orthorexia, we have identified that low food intake is still really highly prevalent among the clients with orthorexia. There is also associated weight loss, and together with this weight loss, there are some dizziness spells, there are tiredness, depression, anxiety, but also to a certain degree a catastrophic thinking. Regarding the treatments that health professionals suggest for orthorexia, it varies, and you can see here in the lower right corner of the screen the possible proposed treatments, including the weight restoration therapies, cognitive behavioral therapy, which actually these two therapies were the most recommended by the health professionals, but also some of them talked about family therapy, group therapy, exposure therapy, and so on. Our other study, which actually included people who self-identify as current or ex-orthorexic clients, showed that there seems to be a snowball effect within the development of this condition. So there seems to be some socio-cultural ideals that were ingrained in the heads of these young people, which were further exacerbated by the social media use and continuous exposure to those ideals on the social media, together with receiving conflicting advice from different websites and different articles. Some of them said you should avoid eating meat. Others said actually a bit of meat is okay. Some of them said drinking a bit of red wine is really good for your cardiac health, while others said alcohol is killing your brain. And having this overwhelming, conflicting flow of information and the lack of ability to differentiate between the advice leads to the development of orthorexic tendencies. Very interesting is the fact that orthorexia nervosa is currently very prevalent in social media, and the social media that is the most associated with the disorder is Instagram. We have performed a few studies on Instagram. Some of them are English language ones, the other ones were focusing on individual countries, and we tried to see what kind of content is there under the hashtag orthorexia on Instagram, what kind of people post about it and why. And in all our studies, we consistently found this duality of Instagram. On the one hand, all the individuals we interviewed said that Instagram plays a considerable role in development of orthorexic behaviors within the individual. But they also all say that Instagram is playing a major role in promoting anti-orthorexia behaviors, because there is this hashtag orthorexia that aims to educate people and create supportive environment for the people who can be facing the difficulties linked to orthorexic behaviors. And also, what we have discovered is that there is no one conceptualization on Instagram. If you look at what kind of information people post on Instagram, it all is very different. And a lot of them are trying to educate people about orthorexia and to try to support people who may be having these symptoms. However, despite the fact that we had a lot of results, and I highly encourage you to maybe Google some of our papers, or maybe contact me and I can send you the papers that we have collected, we also noticed something a bit different. And that is the seeming contradiction that all the respondents, many of the respondents are noting, and that is, on the one hand, there is a lot of felt responsibility in the individuals who develop orthorexic behaviors, that they are responsible for their own health. They are responsible to sustain healthy lifestyle, and if they make wrong decisions, they will damage their own health. On the other hand, what we did notice is that if we go to any kind of supermarket, what we will see is the vast majority of the shelves will contain quite unhealthy food options. So the society and the system of shopping, the supermarkets, are pushing people towards the unhealthy options, yet a lot of individuals are feeling this self-responsibility about the choices they make. So there is quite a lot of mistrust regarding the advice people see on internet, but also advice people receive from the governments or public health officials about what is healthy and what is unhealthy. There seems to be no filter and no control over the information presented to them, which causes a lot of confusion. And they are trying to counterbalance the unhealthy offer from the food market with extreme drive to eat healthy and to actually become quite rigorous in the choices they make. They feel a lot of people who develop orthorexic behaviors are suffering. They are having a lot of impact on their social lives, on their psychological well-being, the high levels of anxiety and stress, possibly depression. But also a lot of them said, well, actually, when I was having orthorexic symptoms, I was unhappy, but I was also a little bit proud because I managed to gain control and I managed to actually go against this mass culture of unhealthy foods. And because of that, I prevailed. I was able to eat healthy and I took care of my health. So, which actually leads to the situation when people are going to the supermarket, seeing a variety of unhealthy options, and then in this strive to gain control back, they go to quite extreme dieting plans. Here you can see a lot of it presented on the slides are about clean eating, detoxing, and intermittent fasting. All of those diets can be quite damaging if done in an unstructured and uncontrolled way. And for some people, it can be okay and they can become quite a healthy eaters, but some people can be tipped over, and such a contradiction and such situation can actually trigger the onset of orthorexia. As I already said, we're doing quite a lot of research on orthorexia. Every year we have more and more studies conducted on the issue. What we're planning to do in the future is to dive into the whole concept of new media and how the new media is influencing orthorexia and development of it as a phenomenon. We also would like to continue working on the defining and redefining the diagnostic criteria by bringing the perspective of individual self into the discussion. And in general, we would like to continue the advocacy for research and policy on the topic. If you find my talk interesting, of course, in such a short period of time, I could only present a glimpse of the studies that we have conducted. But if you would like to be more informed, and if you have any other questions or suggestions about the future of our studies, please feel free to contact me via email. And I hope that you enjoyed my talk. Thank you very much for your attention.
Здравствуйте, коллеги. Итак, о чем я хочу поговорить? Тема как бы не нова, потому что о COVID-19, по-видимому, еще ленивый не говорил, и все обеспокоены, и все перепуганы, и все растеряны, и нет единого прогноза, что будет. Перейдем ли мы в COVID-20, когда это будет массовая иммунизация, когда будет коллективный иммунитет. Поэтому давайте поговорим о том, есть ли жизнь вообще после карантина. Это актуальный вопрос, потому что многие люди выходят на работу после карантина. Карантин опять возвращается, опять выход. Вот этот челлендж устраивает ту ситуацию, когда люди пытаются адаптироваться после вот этого опыта прохождения через стрессовую ситуацию, даже уровень дистрессовой ситуации, к которому не были никто готов. Итак, есть ли жизнь после карантина? Конфликт моих интересов. И, по-видимому, я начну цитату с великого далеко не психолога, не психиатра и даже не врача. Это Джимми Хендрикс, лучшая рок-гитара мира. Чтобы изменить мир, ты должен для начала навести порядок в своей голове. Правильно. Абсолютно верно. И что нам говорит наш мир о нашей голове? А он говорит одно, о том, что пандемия ковида становится иногда и неуправляемой, и она оказалась для нас чрезмерным стрессом. Даже я уже упомянул дистрессовую ситуацию. То есть мы столкнулись с беспрецедентным кризисом в области общественного здравоохранения, которое вызвала вспышка коронавируса, заболевания COVID-19. В силу того, что не пандемия, а социальная ситуация в мире привела нас к этим 4 буквам, и мы действительно проживаем давно в мире нестабильности, неопределенности, сложности, неоднозначности, понятно, что на эту ситуацию COVID-19 как никогда упал и кристаллизовал те проблемы человечества, которые есть сейчас. Не напрасно Оксфордский словарь 2020 года пополнился новыми терминологиями, новыми словами. Это социальное дистанцирование, отдаленная работа, индивидуальные средства защиты. Даже в улочном словаре, в самом популярном, по-видимому, словаре британском, появился новый термин «ковидиот». Да, есть даже определение, вы можете его найти в интернете, и я вполне считаю, что можно дополнить еще одним термином, который называется «ковистресс». Да, действительно, 2 инфекции овладевают миром. Одна реальная вирусная SARS-CoV-2 и вторая вирусная, только виртуально вирусная, ее можно назвать точнее информационно-стрессовой. Поэтому действительно символом 2020 года, даже без всякого нашего желания, становится вот эта маска, которая стала массово не то что популярной, а высокозатребованной и нужной в этом мире. Но я напомню слова Даниэла Деннета, известного когнитивиста, который говорил, что идеям людей свойственны все механизмы вирусного распространения. То есть идеи передаются от человека к человеку, они множатся. Чем большее скопление людей, тем быстрее передаются эти идеи. Они могут даже убить человека с единственной целью – выжить самой идеей. Но не напрасно надо вспомнить Уильяма Исаака Томаса и его теорему, так званую теорему Томаса. Если ситуация воспринимается как реальная, она становится реальна в своих последствиях. Поэтому действительно мы должны оценивать не только биологический ущерб от SARS-CoV-2, мы должны оценивать и психический ущерб от этой вируса, от этой эпидемии, которая перешла в пандемию. Тем более, что типы травмирующих ситуаций меняются. В последние столетия резко возросла скорость и тотальность охвата распространения информации об тех ужасах, которые протекают где угодно, то ли в экономической сфере, то ли на войне, то ли теракты, то ли теперь с пандемией. И появился новый тип травмы, психотравмы, информационной. Об этом начинают все больше и больше писать. Поэтому действительно, собственные фантазии и мысли сами могут по себе уже психической травмой. Известный итальянский философ Агамбен в своем размышлении о чуме вернулся к тому тезису, который он высказал еще в 90-х годах. Сейчас общество больше ни во что не верит, кроме так званой нудовиты, голой жизни. То есть потрясенная пандемией, единственное, что положительно, так то, что люди зададутся вопросом, а правильно ли мы жили. И вот понятие голой жизни и ложное восприятие пандемии, что они создали нового? Альтернативное общение, социальную паранойю, тихую шизоидизацию, коллективные выбросы истерии, сублимацию, суперэгоизм как кови-идиотизм, понимание дозированной по расписанию свободы, принятие идеи голой жизни, персонализацию Бога, разорванный ритуал прощания с мертвыми, осознание неопределенности будущего. Действительно, если страх и тревога, которые сейчас превалируют в обществе на уровне фоновой и даже клинической, продолжают нарастать и становятся неуправляемы, они начинают так называемую регрессивную форму защиты, то есть паранояльный регресс большинства людей. Как примеры, пандемия спровоцирована забросом с космоса, это начало мировой войны сверхдержавы и так далее, и так далее. Достаточно загуглить тему пандемии, откуда пошел новый вирус, как вы выйдете на какие-то суперглобальные идеи, которые являются действительно уже паранояльной формой защиты. Цитируя Нашрала, главного редактора журнала Current Scientry, можно считать, и правильно он сказал, вирусная пандемия создала параллельную эпидемию тревоги. Более того, я считаю, что коронастресс объединил страх с тревогой. Если мы раньше их разделяли, то сейчас понимание конкретного переживания, конкретного ужаса здесь и сейчас проецируется на что со мной будет в будущем, то есть на элементы тревоги. А если учитывать идею Института когнитивного процесса мозга Планка, конкретно работы Вероники Энгерт, о том, что стресс заявляется заразительным, и он как волны расходится и достигает любых куточков планеты Земля, тем более при такой перенасыщенности и такой сплощенности, и по дальнейшей глобализации, когда люди поглощаются большими городами и живут очень плотно один к одному, то понятно, что тревога и страх уже становятся фоновым, на котором любое событие в жизни человека, то ли личностное, то ли глубоко социальное, приводит к тому, что происходит сейчас в психике людей, пораженных COVID-19. Итак, психическое здоровье медиков, задействованных в лечении COVID-19. Конечно, об этом начали писать впервые наши китайские коллеги. Они начали описывать практически у каждого третьего признаки стресса, у каждого второго, у каждого четвертого тревогу и, видите, 13,5% депрессии. И при том, что, в принципе, та же история повторяется по сравнению с другими инфекционными эпидемическими ситуациями прошлого. Конечно же, SARS и тем более испанки. Каково эмоциональное состояние? Интернет-опрос 1029 людей, Китай, конец января 2020 года показал, что большинство людей превалирует тревога, печаль, страх и раздражительность. 14 тысяч людей, 15 стран, большой опрос. И опять, какие психологические последствия самоизоляции, та вынужденная ситуация, к которым прибегают правительства стран, которые поражены COVID-19. Беспокойство по поводу более уязвимых и слабых — первое место, нетерпение побыстрее вернуться к обычной жизни и тревога по поводу собственного здоровья. Какие последствия самоизоляции, те же 14 тысяч, 15 стран? Превалирует, конечно же, тревога. Но тогда надо вспомнить работы наших ученых и зарубежных ученых, которые говорили, что чувства люди, которые пребывают в изоляции, вот в данном случае я цитирую Джулиан Холт-Лунстад, Бриман, люди, которые пребывают в изоляции, это чувство одиночества, вызванное социальной изоляцией, это сравнимо с биологическим каким-то ущербом. Более того, Холт Лунстон сравнивает пребывание человека в изоляции с потерей здоровья, сравнимо с 15 сигаретами в день. Несколько мета-исследований, причем достаточно больших, тоже указывает на эту тему. Смотрите, мета-исследование, которое поглотило анализ 148 исследований, это более 300 тысяч человек. Выводы. Более сильные социальные связи коррелируют с 50% снижением риска ранней смерти. И, естественно, наоборот. А вот еще больше исследования, потому что было проанализировано 70 научных работ, и здесь уже речь шла о миллионах людей. Выводы. Социальная изоляция, одиночество или проживание без семьи и друзей, как они влияли на преждевременную смерть. Так вот, все три фактора, которые я назвал выше, оказались одинаково значимы. А сила их взаимодействия, воздействия сопоставима или даже превышает влияние других хорошо известных факторов, таких как курение или ожирение. Министерство здравоохранения Украины постоянно проводит опросы, постоянно сообщает населению о том, что происходит в стране. По поводу пандемии, заболевших, выздоровевших, умерших, есть официальный телеграм-канал МЗС Украины. Мне интересно было, что в сентябре этого года телеграм-канал МЗС провело опрос с вопросом, что вас больше всего волнует. Она обратилась к украинцам. Я обращаю внимание, что здесь 3 миллиона подписчиков, участников. Естественно, не 3 миллиона ответило, но достаточно много людей. Так вот, я специально для вас показываю скрин этого телеграм-канала. Итак, украинцев в первом месте волнует больше всего, поражает это страх, потом тревога, стараясь об этом не думать, цитата, и смирение. Все равно все рано или позже заболеют. Но вот смирение как раз кажется достаточно пассивной формой защиты и где-то можно оценить как такую субдепрессивную реакцию. Я обращаю ваше внимание на эту публикацию, она мелким шрифтом, она очень интересна тем, что это итог, главное научное открытие о мозге, которое сделали ученые в 2019 году, когда слово эпидемия и пандемия мы даже не проговаривали. Но здесь есть одно открытие, которое вошло в итог 2019 года как лучшая работа о мозге. И оно сделано на полярниках, людях, которые в силу выполнения своих обязанностей пребывают в изоляции. Что происходит с их мозгом? То есть можно экстраполировать на людей, которые пребывают сейчас возле нас, да и нас с вами. Социальная изоляция приводит к уменьшению мозга в объеме. Так вот, уменьшение размера гиппокампа, снижение уровня фактора стимуляции нейропоэза, ухудшение пространственной ориентации и, в конце концов, снижение селективного внимания. Вот что происходит с людьми, которые передерживаются в ситуации изоляции. Поэтому последствия карантина для нашего психического здоровья, это опять публикация в Lancet, которая показывает, за последние 20 лет действительно очень большая работа была проведена, из 3000 статей выбрано 24 работы, которые касались слова изоляция, карантин и другие социальные факторы обеспечения жизни людей. Так вот, за последние 20 лет показало, что на нас больше всего влияет из факторов разлука с близкими и любимыми, выпадение из привычного круга общения, ограничение и лишение свободы, лишение рутины, лишение доступа к базовым товарам и средствам и, естественно, финансовые потери. Что, как реагирует психика? Продолжение той же статьи Ланцета. Это повышенная тревога, это острое стрессовое расстройство, причем встречается втрое чаще, 34% вместо 12%, бессонница, утомляемость, раздражительность, нерешительность. Уже описывают о том, что резко возросла из-за самоизоляции значительный рост зависимости от смартфонов, причем не подросткам, которым мы постоянно кивали, что они уже гаджет-зависимые, а среди взрослых людей. Китайские коллеги описывают, что после атипической пневмонии эпидемии 2003 года медицинские работники длительное время, еще на протяжении 3 лет, злоупотребляли алкоголем и имели проблемы с зависимостью. Я думаю, что эта же ситуация повторяется и фиксируется уже на 2020 год, фиксируется рост симптомов тревоги и депрессии, причем элементы посттравматического стрессового расстройства, слава богу, не в полном варианте, но тем не менее и это есть. описывается о том, что, опять публикация, о том, что мужчины чаще умирают, а страдают от пандемии больше женщин в силу эмоциональной чувствительности. То есть пандемия стала маркером определенной даже гендерной неравенства. И какие наиболее типичные негативные чувства, возникающие в связи с психотравмой, связанные с пандемией? Страх, беспомощность, грусть, тоска, вина, сожаление, стыд, гнев, болезненные воспоминания и, конечно же, разочарование. Не напрасно начали писать наши китайские коллеги, и, по-видимому, стоит обратить внимание о том, что дети, в особенности те, у которых не сформирована еще префронтальная кора, то есть оценка, критичность, понимание, жизненный опыт, у них выявляется чувство самообвинения за то, что они заболели. По-видимому, на это стоит обратить большое внимание, потому что мы формируем невротических или стрессогенно пораженных уже детей в силу того, что они попадают в зону заболеваемости и иногда болеют. Вполне возможно сказать, что эра невротических расстройств конца 20-го, которая сменилась эрой депрессии, об этом писала и до сих пор пишет ВОЗ, тихонько меняется на наших глазах на эру тревожных и стрессовых расстройств. Что происходит? Хронический стресс в силу пандемии. Мужчины злятся, замолкают, агрессируют и пьют. Женщины жалуются, разговаривают, ищут поддержки и заедают. Да, мы считаем, и мы должны выходить из этой ситуации без потерь, как биологических, так и психических. Нормальные реакции нормального человека в ненормальной ситуации: тревога за себя, гнев, тревога за других, страх, вина, одиночество и раздражительность. Мы должны выступать на работу, как бы перечеркнув все эти идеи, но такой клавиши нет ни в вашей голове, ни в моей, ни в нашего населения. Просто класснуть и стереть прошлое не происходит. Даже дефолт-система мозга начинает работать совершенно по-другому. Почему? Да потому что насыщение картинками, которые пугают, информацией, которая в особенности подается визуально, это то же самое, что работа мозга в зависимости от ЛСД. Действительно, дефолт-система мозга начинает, вот этот молчащий мозг, превалирует той ситуации, когда он спонтанно выдает предмысль в виде испуга и тревоги. Какие советы по психологической стабилизации? Да, мы разработали и пытаемся донести в виде каких-то лекций, каких-то методичек, выступлений в интернете, в вебинарах, работа со студентами дистанционно, о том, как надо себя стабилизировать. Сейчас я просто показываю, не перечитываю, о том, что надо привести себя в рутину, привести себя в физиологическую норму, создавать ответственность за кого-то. Естественно, это снижает уровень собственной тревоги. Не подвисать на картинках динамических, в особенности в интернете и телевизоре. И помнить, что мы диктуем свою жизнь. Мы создаем подобные вещи, которые рекомендации, вот эффект окна, периодически менять виды деятельности, хобби, общаться, попытаться себя рассмешить, ароматерапия, фантазирование, даже смешное фантазирование о будущем, о поездках, об отдыхах, что будет включать старые нейронные сети. Мы издаем психологические советы по восстановлению работоспособности, о том, как надо восстанавливаться, как надо входить в работу после длительного самоизоляции или карантина, о том, чтобы не было перегрузки, не было вот этого пика, за которым идет, как правило, разочарование. Мы взываем к руководителям, которые должны понимать, что сейчас ожидать максимальной работоспособности от своих сотрудников, которые действительно и напуганы, и астенизированы вот этой социальной депривацией, конечно же, нельзя. Я показываю несколько слайдов, на которых мы говорим о карантине и как его надо преодолевать, когда ты уже выходишь на работу, как надо разговаривать, как надо избегать тех людей, которые несут вот эту паранойю, которые обязательно будут делиться с вами только ужасной информацией, и понимать, что все равно мы должны приступить. Мы должны вернуться в нормальное физиологическое, поэтому это в наших силах. Нормально высыпаться, не висеть в гаджетах, не нарушать свои циркадные ритмы, действительно создавать свое настроение с самого утра, то есть диктовать, понимая, что вряд ли социум будет думать, как создать тебе хорошее работоспособное настроение. Значит, мы учим людей быть психологически здоровыми эгоистами. Создавайте свое настроение утром сами. Очень хорошо мы убедились, что работает баллендовская группа. Мы сейчас работаем, ведем несколько таких групп для наших коллег, врачей в основном, медработников, и оказалось, что люди не просто соскучились за разговором, они соскучились за профессиональным разговором. Поэтому мы издаем подобные вещи, работаем и считаем, что все эти вещи реально работают. Действительно, надо допускать и перебивки, надо втягивать рутинность, надо втягиваться в ответственность за что-то, не стимулировать себя и не ожидать, что ты будешь сверхактивным, награждать себя какой-то физической активностью. Более того, сейчас мы проводим научную работу, и у нас выполняется диссертация по использованию игры Tetris. Вы помните эту игру, но она показала себя достаточно высокоэффективной в профилактике стрессовых расстройств, поэтому мы работаем и по такому принципу, и учим людей работать в средней степени возбуждения. То есть следовать закону Йеркса-Дотсона. Он действительно реально работает. Еще мы учим людей выключать работу в своей голове, чтобы они не несли какие-то сверхпереживания с работы домой. Поэтому Тетрис и работы, которые вокруг него, я рекомендую просто почитать. Мы начали писать, изучать ситуацию вокруг синдрома профессионального выгорания в украинской среде, среди медицинских работников. Вот такая методичка, которая наполнена 25 QR-кодами, за каждым из которых стоит какое-то видеосообщение, видеообъяснение того или другого симптома, в том числе анализ особенностей именно украинских медиков. Это тоже оказывается достаточно высокая эффективность. Мы пишем книги, которые позволяют как-то учиться преодолевать стрессу, и они оказались достаточно популярными, они в основном подвешены в интернете, их легко найти, прочитать. Книги по преодолению тревоги, книги по преодолению стрессовой ситуации, книги по восстановлению сна. Ну и заканчивание, я, по-видимому, процитирую Мэдисон, университет Висконсин, о том, что у оптимистов уровень антител против вируса гриппа сохраняется после вакцинации дольше, чем у пессимистов. Да, работа выполнена на популяции вируса гриппа и на понимании иммунитета, но я думаю, что вполне можно экстраполировать и на то, что происходит. Мы должны делать все, чтобы оптимизировать население и помнить, что COVID-19 рано или поздно закончится. Поэтому мы и создаем подобные вещи. Это Facebook, страница нашей кафедры, мой YouTube-канал, где я пытаюсь что-то донести, рассказать, не просто успокоить, а вручить конкретные инструменты. Наш журнал «Психосоматическая медицина и общая практика», он представлен в интернете. Там есть наши публикации и размышления, в том числе по COVID-19, поэтому мы работаем здесь, мы готовы сотрудничать, и я считаю, что мы все должны приложить максимум усилия, чтобы наше сотрудничество привело к хорошему результату. Спасибо за то, что слушали, берегите себя, думайте о хорошем и, конечно же, будьте здоровы. Спасибо.
Dear participant of the conference, I'm glad to invite you to discussion, and I hope it gives us the new idea and a new thinking about the mental health care and about our future in so turbulent times. I want to presenting some small results of the research of the Institute of Social and Political Psychology, which we have today, and the topic is the war, media trauma, and teenagers' well-being in digital cyber practices during hybrid war in Ukraine. My small presentation have three parts. The first is about hybrid war in Ukraine and war media trauma. Second, about the impact on teenagers and their digital practices, and about the connection of war media trauma, different types, and our index which we proposed on the teenagers' well-being and their vitality. The first slide is the illustration of the Ukrainian place on the map of the Europe, and Ukrainian map with red segment, which is annexed and occupied regions by Russian Federation. The war, which name hybrid war, start from April 2014, and today we have a very big part of this war in informational space, and hybrid war images you can see at the slide, with the most popular images of the informational war. On the next slide you can see the psychological targets of the informational war, and one of these targets is well-being and vitality, which is the mental health phenomena. On the next slide you can see a small part of the photo which are in the media and represent the war, real war on Donbass, and it is very traumatical picture. The next traumatical picture is the real picture which children on the occupational region can see from their school window. It is the real destruction which caused by war. We have some helping project for educators and pupils, and during these projects we have research about new aspects of cyber practices of teenager during the first year of the war. And on the next slide you can see this is the focus groups which we analyzed, and we find that there are new risks of online practices during hybrid war. It is a lot of pain, it is collapse communication, and the less trust, uncertainty of trust. But internet is a positive resource, and internet is the sign of the peaceful life for children who are in the war regions. And the next slide illustrated our next research, quantity research. The method is the panel this research, which give us test our children and their practices and their components of youth informational behavior, and verificates our idea of war trauma indexes. As we propose three types of war trauma, which cumulative with personal traumatical events, with the relational or secondary traumatical events, and only media impacts. of war image and war topics to children. And we find on the next slide you can see the example of the methodology, but on the next you can see the the results of evaluated of vitality as a opposite depressive scale, which, and you can see that vitality the lower level of vitality have children who have personal accumulated media trauma, and only media trauma have a big comparative with secondary traumatization situation level of the vitality, because we have a idea about role of critical thinking and reflexivity as part of media literacy education, and factor which connected with vitality. And as you see on the slide, all types of media trauma have negative correlation with vitality, and media literacy have a positive correlation with vitality and reflexivity too. But not all part of media literacy have a positive significant effect, because only technical media literacy have not so big correlation. This result give us the possibility to have a conclusion about so we need national level digital and media literacy initiatives, and case of these initiatives during hybrid war must be about digital and psychological well-being, which rise vitality and critical media literacy growth, reflexive practices development, and the whole media educators community building support. We hope to cooperate with international community to promote media education as mental health protection practices during hybrid war. And I hope in future we will have communication about this important topic. Welcome to communicate with our laboratory of psychology, of media communication and media education. Thank you for your attention, and good luck in our future communication.
Good day. My name is Ryan. I am a PhD scholar in the Department of Epidemiology in the High Institute of Public Health, Alexandria University from Egypt, and I'm honored to be with you in this brief session, a fundamental session regarding research writing in public health with epidemiology perspective. So, in this brief session, I would address, from the title, three main keywords: epidemiology, research, and writing. And I'm going to emphasize more upon those keywords in the upcoming slides. As all of us know, the epidemiology, the heart of public health, the basic science in public health, and it is studying upon people, like from the Greek word epi, upon, the make people, and ology, the study. So Why epidemiology is there? Epidemiology basically has many aspects to do with health, from studying distribution of health-related outcomes in terms of person, place, and time, and this is descriptive epidemiology, and explaining why some people might have a certain outcome and others might not. And this is hypothesis generation. It could investigate the association between certain exposures and outcomes, and here comes the analytical epidemiology. It could also maybe stating which exposure might be a causal factor for a certain outcome. This is causality, and it also formulate prevention and control program and help decision makers to find interventions, and finally evaluating those interventions to see whether they were effective or not. So epidemiology is there to, from the very beginning, to research what is good, to research what is there, till formulating a strategy to prevent and control health issues and evaluate them. This slide actually explains briefly the research cycle. I am telling my story about research from my perspective with this epidemiology, but it is fitting every certain discipline because it's a fundamental basic level. So in health, we all encounter issues and problems that spark our mind with ideas, and those ideas could be actually formulated into a research question. And we could go from there into translating those research questions into hypotheses and testing the hypotheses with suitable study design and proceeding to results. And those results actually making the body of knowledge and adding to the body of knowledge towards producing the evidence we use in clinical practice. In this slide, I have some other keywords that I would address in the upcoming slides: research question and study design and evidence. The research question in epidemiology is stated in the PICO format, and P stands for population or problem. So I have some subjects. Those are my population with certain health condition or event or exposure or whatever problem or issue. I would try something upon them or observe something on them in a form of intervention or others, and compare those group with other group to make an inference and see whatever outcome that comes. And then I make my inference through results. So basically, I have a PICO research question that takes my sample towards the outcome. As I stated in the research cycle slide, the research question is formulated into hypothesis, which is tested via study designs. And in epidemiology, we have main two arms of study designs, and those are experimental or interventional studies, and then we have the non-experimental observational studies. I will go through them briefly. In experimental or interventional studies, where we as investigators, researchers intervene, we do something for our samples. It is those studies divided into randomized controlled trials or clinical trials, and the others with non-randomization, like quasi-experimental or field or community trials, where my sample would be populations or groups, not individuals. And in the other arm, we have the non-experimental observational studies, where investigator-led nature takes its course, and it is subdivided into population-based studies and a descriptive one in the form of health surveys. or maybe analytical one like ecological studies, health surveys as, for example, studying maybe consuming healthy diets in a certain population. And analytical ecological studies, maybe, for example, studying the effect of environmental hazards, chemicals, or other source of maybe insecticides or other environmental hazard. In the arm of individual-based, non-experimental observational studies, we will notice that is further subdivided into descriptive and descriptive individual-based observational studies, are mainly the case report and case series. And case report, basically, as you know, it is describing characteristics of a unique case, maybe a rare condition for one patient, like we've been hit by COVID-19 in 2019, and the very first case was discovered and described this way. The analysis, actually, symptoms were stated, patient characteristics, what diagnoses have been done, prognosis of the condition, and therapies taken, other investigations, just describing what's happening with a single patient. If we gathered some similar patients, we could make a series and describe as well. In descriptive arm, actually, the cross-sectional study could fit here, but it also could fit in the analytical observational studies if we made some analysis upon it. And the cross-sectional studies basically is a snapshot in time. In a certain time, I would maybe study exposures and outcomes at the same time, and studying them in form of description. So it is descriptive. If I made analysis and made some statistics on them, then I have analytical type cross-sectional study. So in the arm of analytical observational studies, we have the cross-sectional or the prevalence study, and the main measure I get from the cross-sectional studies is the prevalence. So it's called also prevalence study. And we have also the case control studies or case reference. And we have also the cohort study or follow-up studies. I'm going to emphasize more on those subtypes of the analytical observational studies due to their greater impact in epidemiology. So this graph, this cartoon, actually stating basically the case control observational study design. So here I am searching for exposures. So I'm starting with a group of diseased patients, those are my cases, and I match with similar controls except they don't have the case under study. I look back in time to see what are odds of exposure in cases versus controls. I search for what might cause their illness and compare with controls. In the cohort study, it is as well observational study. I sample from my population some participants to be my study population, and then I subdivide them into a group of exposed subjects and another group of non-exposed subjects to a certain factor, and I basically follow them up on time. So it is a follow-up study. It's also called a follow-up or prospective study to see if they develop a certain disease or outcome. So the case control will be retrospective and cohort mainly prospective, and of course there is another type of cohort where it is a retrospective, but the popular one is the impactful, more impactful one, and harder to execute is the prospective one. And regarding study designs, I would also mention the randomized controlled trials, the gold standard in research, where we have to sample some random sample from our population, and then we do further randomization into at least 2 study arms: the experimental group or the interventional group, where the investigator adds something or withdraws something, and the control or comparison group, where the investigator might not give anything at all, or give a placebo, or give the standard of care if he's studying a new medication for a certain condition that has already a medication in the market. And then I follow them up on time, so it is as well a prospective follow-up study, and compare results. In this slide, I thought it is important to highlight drug development process, because mainly it is based on epidemiological study designs. It is a daunting process to discover a medication or vaccine, as we are witnessing now, searching for a COVID vaccine, and the race to make the vaccine available for winter, and searching for therapeutics for treating COVID. So the basic process of developing medication or a vaccine, it's simplified here in this graph, and it takes many years. We start basically from a computer, searching for a drug candidate that fits the receptor and software. It takes many years, maybe reaching 3 years. And then when we have a promising candidate, we would take it into a lab and test it on animals. And here comes non-clinical studies. It takes years, might reach 5 years. And after having a promising results on animals, we tend to take it to clinical level on patients or individuals, subjects, human beings. Clinical studies are subdivided into, as you know, 3 phases. Phase 1, where I use a small sample of healthy volunteers to test the safety of tolerability of my medication, and then if it went well, I will proceed into phase 2, where I'm testing the formula of the medication on a larger group of subjects, and those basically patients. I'm seeing aspects like the pharmacokinetics, absorption, distribution, metabolism, and excretion, dosage form scheduling, and this sort of stuff. And then if it is going so well in phase 2, I will proceed in phase 3. And phase 3 actually is the real randomized controlled clinical trial if it is formulated this way. Here I compare a larger group of patients with another control group to see the efficacy of this medication for a longer period of time, of course on a larger sample of patients. This arm, phase 3, it has comparison group like phase 2 and phase 1. So this is, and it could be actually randomized and blinded, so those are the real city. If it went well in phase 3 on patients and compared to control group, of course, it would make a candidate drug for approval by authorities, health authorities. So regulating body would receive a request for approval, and when it is approved, it will get to the marketed to patients, and we would have another phase of clinical studies, and it is post-marketing surveillance. It is a massive phase. It is actually following the drug effect and side effects upon populations, larger groups of patients. We here tend to see rare side effects and delayed effects that wouldn't appear in the confined, time-limited clinical studies. So I have discussed so far from the research cycle keywords, the research question keyword, and study design keywords. And actually, to answer certain research question, I have to select a specific study design. So this is a slide that is table stating briefly each type of question answered with a specific, or fits a specific study design. For example, intervention, testing, medication would greatly benefit from the randomized controlled trial. etiology question, searching for risk factors. Of course, it would benefit from randomized control trials as it is the gold standard, but actually it could benefit from cohort and case control more. Why? Because risk factors might be hazardous. Yes, it is risk after all, and it might be unethical to proceed with a randomized control trial to see a risk. So it would be more ethical to go with cohort case control, as those are observational studies letting nature takes its course. When asking a question regarding frequency and rates numbers, we tend to use cohort or cross-sectional. Cohort would yield actually incidence rates. There was no cases of condition, and prevalence, of course, the caseload would be yielded from cross-sectional studies. When I'm seeking diagnosis, I could use as well cross-sectional studies. My question, if it is regarding diagnosis, when I am seeking the prognosis prediction of the course of disease, cohort study or survival analysis would fit well. Okay, the study designs I stated are formulating the primary evidence, primary literature, the base of the evidence. Those study designs are ranked in a hierarchy from the highly biased one to the least biased one. And the highly biased one, of course, the less controlled. Cross-sectional case report and case series, those are descriptive observational, and then the cross-sectional. And then we step up towards the analytical observational, case control, and then cohort. And then finally, the randomized control trial is the least biased one. So the experimental controlled design would be of a greater impact on evidence. Based on the previous slide, as I stated before, the study designs explained in the previous slides, formulating the base of my evidence, and the evidence is the third keyword I stated in the slide of research cycle. We have mentioned research question and then study design, and the third word is evidence. Actually, evidence is formulated from my primary studies, and primary studies are the base of this pyramid. This pyramid, the 4S evolution of services, health services. Regional studies are the base, and then we step up to a more stronger evidence. When I gather similar studies with rigorous criteria and I do some statistics upon them to make systematic review and maybe a Cochrane review that is highly peer-reviewed from Cochrane experts, it will be a synthesis. And when I step up and abstracting knowledge of these syntheses and making guidelines, it will be synopsis. And when I step up and making systems like feeding a computer software with the body of knowledge, recent body of knowledge, and patient data, and customizing solutions and interventions based on both knowledge, this is highly unique. Like computerized decision support systems, this is the highest and the top level of evidence, the highest quality of evidence. So this pyramid, organizing my evidence as I take it from my research primary studies as investigator, step up towards making decisions upon individuals. Okay, so far we have discussed two keywords, epidemiology and research in epidemiology, that went through other three keywords. Those were research questions, study designs, and evidence. So we have to communicate what we have reached in research to our colleagues and to the public by writing. So this is the basic format paper, and we are as researchers in this conference, for example, we have to submit our work in this basic format. that has our title and abstract, and keywords, and then the body of the paper stating our introduction and methods, results, and going through discussions, and finally stating our conclusions and thanking everybody who helped us in this work and making references to other works and adding maybe some supplementary materials. And this paper manuscript would go through a daunting journey towards publication. It would be submitted for editorial review, and then the editor send it to a reviewer, and then the reviewer do his work and send it back to the editor with comments to be communicated for the author, if it is accepted actually with condition. And it could be rejected, and it is sad, but it is not the end of the world. If it is rejected, we would make enhancements, and we would maybe send it later on for another journal or conference till approval. But we have to stick to the reviewer comments, justify if we didn't go through those comments, and we should enhance our manuscripts towards publication. In this conference, I would say that it should have plenty of experts in field and newbies in research. So two main bodies of publishers, reputable publishers, Elsevier and Taylor and Francis, made academies for teaching research. And the Research Academy for Elsevier, as shown in this slide, it is a great place where a newbie or maybe someone searching for a specific aspect and wants to know more about it, from research preparation, writing process, application process, and be reviewing and communicating research. It's a great resource actually. And Taylor and Francis making series with chapters, maybe 12 chapters as far as I can remember, how researchers change the world, and it is a great resource as well. So, so far I have been through my 3 keywords. I'm reaching them back, epidemiology research and communicating research towards writing. And of course, epidemiology is a basic science of public health, and another aspects of public health, mental health. Mental health is highly impactful field of public health, and it is it goes through the same research process in writing aspects, and making research in this way, like I stated before, would add to the body of knowledge, and it would be used by clinicians. We are researchers and clinicians. Some of us are clinicians practicing medicine on patients. So we would make use of this research evidence on our individual patients. So we have the epidemiology and the clinical epidemiology, applying those, translating those research results and evidence upon individual patients. And here comes applying maybe the outcome of research on psychiatric patients and so on. I'm trying to link things together as all sciences are linked together. Okay, before I leave you, I would leave some questions to for you to think about, and I would ask myself as well those questions. Why I want to publish my work, and let's make a good manuscript. You could think yourself about them, and I would think as well, and I would share my answers with you. Actually, I would want to publish my work if it is new, if it is challenging, if it is a trendy topic like about COVID and all people addressing COVID right now because it's a hot topic, and if it is adding something or solving something, adding solution. If those are yes to all those questions, I answered yes. So my manuscript, from my perspective, and I guess from the editor's perspectives, would worth publishing. A good manuscript, to me, should have a scientific message that is useful and exciting the same way. And it should communicate my thoughts in a logical manner so as the reader could perceive them as I compose them. And it should be in the best format that showcases my materials and written, of course, in a style that is clear to transfer this message. So I have reached the end of my session. It was a fundamental session addressing writing research, health from epidemiology perspectives, and of course it fits everywhere in the other public health sub-disciplines like mental health. I enjoyed being with you, and thank you.
Hello, my name is Chrysostomou. I'm studying medicine at the University of Crete in Greece, and today I'm going to elaborate on the Hippocratic account of mental health with a focus on humor and human temperament. Hippocrates, as you may know, was a Greek physician of the 5th century before Christ. He is the so-called father of medicine, and his main contribution to medicine, apart from the Hippocratic Oath and his ethics, is the scientification of medicine. The fact that he founded a scientific school of medicine, and together with his disciples, he established medicine as an art with a scientific approach. All in all, he focused on founding etiological correlations through keen observations of patients and disease. His main work is called the Hippocratic Corpus. It is a collective work of himself and his disciples, and it promotes the systematic study of clinical medicine, summarizing the knowledge of the era and at the same time establishing good practices for physicians. When it comes to mental health, the Hippocratic Corpus provides perhaps the first account of scientific mental health, and the main elements behind this are humors and human temperament. The aim of this presentation and this work in general is to summarize the Hippocratic account of mental health, discussing the terms of humors and human temperament in the context of his own work and in correlation with modern literature. In this study we focused on the Hippocratic Corpus and on the terms that we have mentioned. We worked on the original text of Hippocrates and received additional information from Aristotle, where there are extensive treatises about the anatomy and physiology of human body. Of course, information extracted from these texts, the original ancient texts, was subsequently evaluated on the basis of modern biomedical literature in order to establish their validity and draw conclusions. So, the main element of Hippocratic medicine is what is known as humoral theory. Humoral theory is describing the human body as an equilibrium of blood, phlegm, yellow and black bile. This derives from cosmology and correlates with the 4 elements of the weather. All in all, when there is an equilibrium between these elements, which is unique for its person and is called idiosyncrasia, this person is healthy. In case this equilibrium is changed and one or more of these elements prevail, we have a disturbance of idiosyncrasia. This is called dyscrasia in ancient Greek, and this results into disease. So the mental health and the mental health conditions that we know today and that Hippocrates and his disciples were observing and tried to identify and explain at their time were interpreted through this system. More specifically, we have 4 humors, as we mentioned: yellow bile, it resides in the liver and it resembles the element of fire. Black bile resides in the spleen and it resembles the element of earth. Phlegm resembles the element of water and it can be found in the brain. And last but not least, blood is alike to air and represents heart. It resides in the heart. The connection between cosmological elements like fire, earth, water and air and organs and elements of the human body comes from the pre-Socratic philosophers. Let's be a bit more specific about this. When it comes to mental health, the predominance of a humor, even within normal values, within a physiological state of mentality, creates a typology of characters. But at the same time, this typology is not absolute because at this very characterization of this very typological system, environmental factors such as the air, water, and generally climatic conditions are taken into account. For example, a person in whom the blood prevails is a person driven by the heart. His temperament is sanguine, and when it comes to character, it has to do with being courageous, hopeful, playful, and carefree. A person in whom the yellow bile prevails is a person dominated by his liver. He is called choleric in terms of temperament, and he is an ambitious leader who is restless, and at the same time he may be easily angered. On the other hand, a person who is dominated by black bile is a melancholic person. He is dominated by the spleen, and we all understand that a melancholic person is someone who is quiet, analytical, serious, and in some cases depressed. Last but not least, when it comes to phlegm, we are talking about a person who is dominated by the brain. He is phlegmatic, and this term survives till today and refers to a person who is calm, thoughtful, patient and peaceful. So we have an account of mental health, mental well-being according to humors and temperaments, and we also have an account of mental disorders, mental disease in correlation with temperaments. It is not a surprise that many of the terms that Hippocrates and his colleagues used survive till today. We all know mania, melancholy, phrenitis, insanity, epilepsy, panic, hysteria, paranoia, and many more. And what made his explanation and his observations unique at the time was the fact that apart from devising a management strategy of patients presenting with these conditions, he also tried to correlate them with the physiology of the human body. For example, epilepsy at his time was considered a sacred illness because the symptoms were strange, the disease was recurrent, and at the same time magicians and purists, but also doctors of the time, were unable to treat this. Epilepsy today is a condition of recurrent, unprovoked or provoked seizures, and it has numerous cases, from genetic to environmental cases, intrinsic and extrinsic cases. Its onset usually indicates a pattern of brain dysfunction that may be intrinsic or maybe has to do with brain injury and ischemic damage. In ancient Greek literature, many times the symptoms of epilepsy are correlated with mental illness. And there is a very characteristic example of the Persian king Cambyses, the son of Kyros the Great, who went mad, killing people in his close environment, including his own brother. And he is described by Herodotus as a person afflicted by seizures. And later, Hippocrates has endorsed this interpretation of Herodotus and described also Cambyses as a person suffering from seizures, which altered his mental well-being and his mental balance. A very common example is melancholia, a lot of black bile. So we have symptoms of bad mood, but we also have symptoms of dangerous mood. It is probably what we know today as suicidal thoughts or self-damaging views. In the texts of Hippocrates, we have aposkepsias, this means instillation of liquids. We have apoplexias, which is mania. We also have lingual expression that becomes more insulting, let's say. This is akratia in terms of logos, which is speech. And it is also reason. So this person, the person suffering from melancholia in Hippocrates, may also suffer from epilepsy, seizures, and depression. Nowadays, we also know that there is a comorbidity of epilepsy and depression, and we also know that there are two facets of psychiatric diseases. These are mania and depression, and in people with bipolar disorder, these two facets may coexist. These observations were later also confirmed by Galen. Galen was the father of Roman medicine, probably, and he resonated in many terms with Hippocrates. So what we can understand from this Hippocratic account and the treatise of mental health and well-being, which is something outdated, and probably we can't understand why do we have to discuss this today. Well, psychiatric diagnosis and neuroscience have advanced quite a lot. If we compare the era of Hippocrates and the 21st century, our own era, we will observe a lack of technical means. Hippocrates didn't have a functional MRI, but nowadays we also have a lack of funding. A few months ago, research on Alzheimer and dementia was seized from major sponsors, meaning that in both cases we have lack of the technical means that will help physicians and researchers to advance their approach. In the era of Hippocrates, we had different epistemology than now. We are now looking for publications and for conferences. In the era of Hippocrates, Socrates was a thought leader, and as a thinking leader, he emphasized on speech. According to him, written speech, publications and books and chapters and so on do not worth, because you can't interrogate the author, you can't interrogate the one who communicates these ideas. So imagine a doctor trying to put down his observations and his scientific treatises as a gift, as a form of scientific communication with his peers, while the major scientific ideology doesn't approve this kind of scientific communication. Nowadays in psychiatry and neuroscience, we also meet controversy over facilities and models of treatment. We have closed psychiatric structures, hospitals, and at the same time many people advocate for day clinics or open treatment modules. At the same time, of course, there is a lot of controversy between classical psychiatry, psychoanalysis, and several variants of both. In both eras, we have strong popular beliefs. The stigma of psychiatric disease was a thing at the era of Hippocrates and is still a thing even in the Western world. And what seems peculiar with Hippocrates, the fact that he tries to link cosmology and the weather with humors and mental health, is something that today is totally acceptable because we are discussing environmental health and socio-biological translation, how factors from the weather, factors from the social and natural environment can affect human health, not only instantly, but in a long time. And to conclude with, we understand that Corpus Hippocraticum cannot be taken by word, but is a source of inspiration and good practices. With good practices, we mean empathetic communication, thorough history taking, especially in patients with mental illnesses, and perhaps communication of patients' narratives with colleagues. Future studies may identify such practices and investigate their feasibility in the context of modern healthcare and their efficacy also in the context of modern mental health facilities. Honorable academics, dear colleagues, the topic of this presentation is hypoxic-hyperoxic training in dementia. This is a novel treatment that has a lot of similarities with Mithridatism. In this presentation, we are going to go through dementia with a focus on its epidemiology, pathophysiology, and the role of hypoxia in its pathogenesis. After that, we are going to present the purpose and the methods of this study. We are going to discuss the results in terms of basic research and clinical studies, and we are also going to present some conclusions from these results. Let's start with the epidemiology of dementia. It is a serious neurocognitive disorder which can have a very important impact on patients, families, the health system, and the economy in general. Globally, its prevalence in 2010 was 35.6 million individuals, and it is growing in great numbers in the next few decades. Of course, dementia is a disease that afflicts mainly elder population, people who are over the age of 65. Universally, the main reason probably for dementia is longevity, as ironic as it may seem. People aging is connected to the onset of dementia, and the more people who exceed the 65 years of life, the more people will be afflicted from dementia. In terms of pathophysiology, the main hypotheses have to do with amyloid plaques and neurofibrillary tangles. Essentially, amyloid plaques consist of proteins that are misfolded and are accumulated on neurons. We don't really know the physiological role of amyloid in the brain, however, it seems that it contributes to neuronal transmission. Of course, when accumulated, it probably hinders neuronal transmission, leading to defects that we usually see in dementia. Schematically, we have the concept of prion pathways that are included in all neurodegenerative disorders that first appear in elderly people. Natural cell proteins like amyloid are for some reasons, for genetic reasons, hereditary reasons, or environmental reasons, misfolded, and this works as a domino effect, as a bad role model, forcing likely other proteins to misfold and leading to the accumulation of these products on neurons, hindering neuronal transmission. What is the role of hypoxia in this model? Hypoxia regulates the metabolism of amyloid plaques protein. The more hypoxia we have, the less oxygen that reaches the brain, the more is the amyloid model, the accumulation of amyloid plaques promoted. One reason why this is happening is that hypoxia can cause a deregulation of calcium homeostasis. This is something we have seen in experimental models, and this leads to the aggregation of amyloid plaques. We also have some reverse proof for this from other studies, which have tested beta or gamma secretase inhibitors that eliminated the effect of hypoxia on calcium homeostasis. In these studies, it appeared that we didn't have the aggregation phenomenon of AB plaques after decreasing the effect of hypoxia on calcium metabolism. So all in all, it seems that hypoxia is something that may happen in many tissues of the body, especially in elderly population, from the heart to the kidneys and the brain, can promote the aggregation of the main pathophysiological findings in Alzheimer's disease and other dementia spectrum diseases. And in this picture you can see that hypoxia is a multifaceted condition affecting many organs and also affecting the brain and causing hypoxia through many pathways. So the purpose of this study is to review the current evidence about hypoxic-hyperoxic treatment, a treatment that focuses exactly on these pathophysiological mechanisms and all the sub-mechanisms that may be involved in this. We have conducted a literature review. I don't want to go through the details of our search. We searched in PubMed and Google Scholar with the algorithm that you can read here. And we focused on clinical trials, on basic research studies, and we included original research in English or Russian. Now my colleague will present the results of our study.
Hello, I will talk about the results now. There are studies, both clinical and basic researches, that show that determined hypoxic-hyperoxic treatment can reduce dementia and generally Alzheimer's disease or mild cognitive impairment, which is a precursor of Alzheimer's disease. It is known that it is already known that in Alzheimer's disease, the main pathological evidence is the presence of amyloid plaques. So clinical data has shown that in Alzheimer's disease we have reduced cerebral perfusion, which leads to hypoxia. So we can say that hypoxia is like an inevitable consequence of the hypoperfusion, and oxygen supply in the brain may have a positive impact. Studies have shown that the normobaric hyperoxia provides more oxygen and is protective. This can be shown in the Morris water maze test, which shows that normobaric hyperoxia improves spatial learning and memory, shown in transgenic mice, and also decreases amyloid beta deposition and neuritic plaques formed in the cortex and the hippocampal regions of the same transgenic mice. So from this, it is suggested that normobaric hyperoxia may have a potential therapeutic effect at the early stages of Alzheimer's disease. Another study focuses on the effects of normobaric hypoxia exposure on memory and physiology of the human body, as well as the physiological and cognitive effects of oxygen breathing before and after this exposure. For this study, 86 healthy men were divided into 4 groups. The first group, normoxia air group, patients were breathing air. In the second one, hypoxia air group, patients were exposed to normobaric hypoxia and air breathing. In the normoxia oxygen group, it's similar to normoxia air group with the addition of 100% oxygen breathing periods. And in the hypoxia oxygen group, we have participants who are exposed to 100% oxygen before and after the exposure. Patients from all groups were subjected to some tests, like the Pace-Auditory serial addition test, which is performed to test the memory, and also peripheral vascular oxygen saturation, heart rate, and electroencephalogram were recorded. Results from these studies showed that acute normobaric hypoxia exposure caused a typical physiological response like decrease in peripheral oxygen saturation and increase in heart rate, but not the same as the physiological response to acute hypobaric hypoxia. Also, there is impairment in working memory, and oxygen breathing after non-baric hypoxia exposure causes slowing in the electroencephalogram. It's associated with making working memory ability worse. So for this reason, it is suggested that normobaric hypoxia needs to be surrounded by air breathing. The next study, researchers used quantitative proton magnetic resonance spectroscopy to evaluate the regional metabolic alterations after a 24-hour hypoxic or hyperoxic exposure in an ischemic brain. So 60 female Louisa rats were divided in two age groups, the young group until 3 months old and the age group until 24 months old. Each age group was further subdivided into 3 subgroups of 10 rats each, and 2 of these were anesthetized after overnight fast, and cerebral ischemia was induced to them. Extracts were taken from 3 different brain regions from both hemispheres, like frontoparietal and occipital cortices and hippocampus, and concentrations of 8 metabolites were measured. These metabolites are alanine, choline-containing compounds, total creatine, gamma-aminobutyric acid, glutamate, lactate, myo-inositol, and acetyl aspartate. This showed that in the controlled normoxic condition, there were significant increases in lactate and myo-inositol concentrations in the hippocampus of the aged rats in comparison with the hippocampus of the young ones. In the ischemia hypoxic condition, the most important changes in the brain metabolites were found in the hippocampal regions of both young and aged rats, but in the aged animals it was more prominent. The ischemia hyperoxia procedure caused less changes in the brain metabolites, which may indicate more limited tissue damage. It's already well known that chronic hypoxia stimulates angiogenesis in brain and generally in other tissues, so therapeutic intermittent hypoxic training can improve vascularity of the brain and prevent Alzheimer's disease. Now, let's move into the clinical studies. In 2017, Mlingi Bwire et al. Made a study. They studied 34 patients aged between 64 and 92, which were divided into 2 groups. The first group, experimental group EG, the patients received randomly MTP and IHHT, whereas in the experimental group CG, they received MTP and placebo breathing with machine face mask. Before and after this 5 to 7 week trial, cognitive function was evaluated by the dementia detection test or DEMTECT, and the Sunderland clock drawing test, and functional exercise capacity by the total distance of the 6-minute walk test. Results showed that after the MTI and IHHT was administered, DEMTECT showed important improvement, as well as the 6-minute walk test, with a larger increase in EG in the experimental group EG than in the experimental group CG. And here you can see also the numbers. The CDT also showed similar results with DEMTECT, with an increase in group EG, but decrease in group CG. And there was found to be a relation between the changes of the 6-minute walk test, the DEMTECT, and the CDT test. Then in 2019, Bwire et al. They updated the previous study. It happened same as before. They used 34 patients, divided into 2 groups. But here we have the addition of some more tests. So mobility was assessed, while perceived health was evaluated by one part of the EG5D test. This test showed that after the MTI plus IHHT or normoxial sessions, results of these tests revealed no significant difference between HG and NG. The study indicated that IHHT added to MTI did not cause any additional improvements in patients' health and mobility compared to MTI alone. And lastly, another one study in 2019 by Serebrovska et al. They examined the effects of intermittent hypoxic-hyperoxic training in patients with mild cognitive impairment. For this study, they used 21 participants, ages between 51 and 74 years of age, which were divided into 3 groups: healthy control, MCI plus sham, and MCI plus intermittent hypoxic-hyperoxic training. And then intermittent hypoxic-hyperoxic training was performed. Was performed 5 times per week for 3 weeks, which means a total of 15 sessions. The results from this study. So first, we have an initial decline in cognitive function indices in both groups 2 and 3. We have connections found between cognitive test scores and the levels of circulating biomarkers of Alzheimer's disease, and the intermittent hypoxic-hyperoxic training resulted in the improvement in cognitive test scores, along with significant increases in APP ratio and decrease in amyloid beta expression and METs formation. Thank you very much.
Moving now to the discussion, we understand that some of our results were aligned to previous studies and other results were in contrast to previous studies. When it comes to similar results, we have seen also previous review studies highlighting the fact that there is encouraging but limited evidence regarding the use of hypoxic-hyperoxic treatment in dementia. Another interesting finding is the variability of the outcomes of this therapy, and probably genetic traits, hereditary factors are involved in this variability. This is something that we can also understand from our own interpretation of the existing evidence. On the other hand, we may agree with the existing sources that hypoxic and hyperoxic treatment can be a therapy for Alzheimer and other dementia spectrum conditions. However, there is no evidence that they can prevent the onset of dementia or mild cognitive impairment in healthy individuals. Of course, the interplay between preclinical and the clinical studies is also notable. We have seen basic research and clinical research projects running at the same time. Basic research was initiated before clinical research but was continued while clinical studies were conducted. But what we have not seen is translational research, and this is something that it is very useful in the context of genetic traits involved in the outcomes of this intervention. For example, if we had a translational research project, we could examine which genes or which proteins are involved in the variability of outcomes and make the selection of patients more specific and more effective, perhaps. However, there is also an important consideration, and it has to do with safety. In one study, it was observed that using oxygen, reoxygenating after acute normobaric hypoxia could slow down the cerebral activity, harming the recovery of memory this way. This is a very important consideration which needs to be further investigated before implementing this treatment. The limitations and the opportunities or challenges of this field. The main limitation of our study is that it is a narrative review and not a systematic one. On the other hand, the existing evidence is limited, and we don't really know whether a systematic review at this point would be really useful. However, wherever lies problem, there is also opportunity, and this is an opportunity for more studies, studies in translational settings, studies that would recruit larger population, especially patients who seem to have better outcomes in contrast to healthy individuals. And of course, in this context, hypoxic, hyperoxic treatment can be examined as a component of multimodal interventions, pharmacological and non-pharmacological interventions to the treatment of dementia. There is still one point that we haven't explained, and this is mithridatism. As you may know, mithridatism derives from Mithridates, the sixth king of Pontus, who reigned there at the 1st century before Christ. Mithridates would consume non-lethal amounts of poison in order to create a sort of tolerance and protect himself from poisoning. His tactic was so effective that when he suffered a tremendous defeat and he wanted to take his own life by poisoning himself, he failed. And as a result of it, he had to ask one of his bodyguards to take his life with a sword. Going back from the battlefield and Mithridates to our own field, to dementia and its treatment, we observe that hypoxic, hyperoxic treatment follows a similar pattern. We use hypoxia, a genuinely toxic factor for the central nervous system, for neuronal integrity and memory, as a training stimulus in order to create tolerance against ischemia that may occur because of rheumatic disease, because of strokes, and because of many other conditions. And at the end of the day, we try to safeguard human memory this way, by conditioning human memory with a condition that leads to its degradation. So this is the similarity and the interplay between Mithridatism back in the 1st century BC and hypoxic, hyperoxic treatment in dementia today. One of the aspects of dementia that we didn't have the chance to mention was the fact that the number and the population of neurons is also decreased by years and as age progresses. This is something that you can see in this artwork here. Thank you very much for your attention.
I'm so pleased to be part of this Congress, and I really wished to be there and to meet you in person. But let's do our best introducing some new approaches in therapeutic process. I'm Adelina Pietra from Albania. I'm a clinical psychologist, EMDR therapist, BWRT therapist. Also, I am the president of Mental Health Albania. Today, I'm going to talk a little bit or a little more about BWRT. BWRT is a new approach in treating mental health issues all over the world. As this world goes fast and everything is faster, it's right to use some approaches that are as fast as the world goes. So this is the BWRT therapy. But what is this therapy? BWRT was created in 2011 by Terence Watts, a therapist, author of many books and trainings courses and principal of Essex Institute in UK. Like many great ideas, it was born out of a moment of inspiration while reading about some experiments carried out in 1983. And here we are talking about a Libet experiment, which appeared to show that we don't actually have free will in the way we usually think of it. More than that, it showed that the decisions were made and acted upon by our mental process before we became aware of them. It was immediately evident that this process accounted for a huge number of the physical difficulties, psychological difficulties, which so many people have to put up with. And obvious that with some research, it could provide the basis for a profound therapeutic intervention, something that is potentially more powerful and effective than anything that existed to date. Terence had for some time been working on an idea to work with several complicated issues, like why we sometimes can stop ourselves doing things, why we sometimes feel that we just cannot do something we would really like to, why we so often limit ourselves from getting on with life, why we sometimes give up on something without even trying properly to do it, why we sometimes fear of something when there's no real reason to do so, why some situations triggers uncomfortable feelings, even thoughts we have no idea why therapy doesn't always work as we want it to do so. The research, investigation, and analysis Terence had carried out so far had raised almost as many questions as answers. He was unwilling, thought, to accept that this was just the way things are, and it was reading about 1983 experiments that the key to the entire puzzle exploded into Terence's mind. He began working on the project immediately, and it soon became evident that here was something very special indeed. Something that worked in a way that was different from anything that had gone before. After extensive testing, a training program was implemented and rapidly gained the reputation among many therapists as a must-have process for working with all manner of issues. It was shortly after that he became an independent training organization dedicated solely to the training of this particular process. What Terence says is, after working with all sorts of different people for years, I became more and more fascinated by the way the mind works. He studied hypnotherapy, CBT, EFT, among many other therapies, but always he thought that there was something lacking. And also me, I felt so. Something is missing. And how to realize a new way of thinking, most therapies require repetitive sessions and activities that the client must continue to do for them in order to be effective. The more Terence practiced and studied, the more he realized that there is no such thing as free will in the typical sense. For many of your thoughts, behaviors, and habits, there is a response to a situation or emotion formed long before you come to understand it. But what is this therapy, BWRT, brain working recursive therapy? It is a new model of psychology and psychopathology that fits well with current thinking in neuroscience. It is defined in the way of focused problem solving, and thus this meets the main requirements of modern therapies. Perhaps the most important thing about it is that it is really unique, completely scientific, and works in a completely different way from therapies like CBT, EMDR, NLP, counseling, hypnotherapy, or other similar therapies. Telling the truth is totally different, has nothing in common with any other process in therapeutic. BWRT is a groundbreaking therapy that works using the normal function of the brain. How? By changing the communications performed within neurons. Neurons are highly specialized nerve cells and are responsible for communicating information in both chemical and electrical forms. communications performed by neurons are shaped by our past lessons and experiences. But how does it work, brain work and recursive therapy? BWRT allows you to generate a different neural response. In other words, another mental response before reacting to something. The change can be so natural that the client will not even notice the subtle intervention. Did you ever say it? Why do I keep doing this? Or I wish I didn't not do or say this. So have you been in this kind of situation? If there is a stimulus related pattern, activate it immediately before there is any conscious interventions. This now provides a clear and understandable answer to the old question: why my unconscious does things that I do not want? Your brain is an amazing thing. It is constantly calculating a stream of data from all your senses while referring to memories, and it is automatically making decisions as you go about your day, trying to make sense of everything that listen and watch. BWRT makes it possible through a simple technique to create a new response pattern for each stimulus, so that the action triggered by the brain is what we want. The therapy is completely without in-depth history, so very different from other therapies. And it's that kind of therapy that I can apply with even my colleagues or my family members, because I don't go in deep in history. So the client should not tell the therapist about very sensitive or intimate issues, making the therapy much easier to apply in a large number of situations. Not only situations, but even in a large number of people, even for VIP people that have difficulty talking with anybody, keeping their secrets. So this therapy makes possible to work through a problem without going in depth history or too much details of something in their life. This therapy does not apply tapping, touching, holding hands, or anything else that might be thought weird. The other great thing about this is that we do not need to find the initial awareness event to work with BWRT. We only need the worst or strongest memory of the symptom that the client can consciously find. So during the process, we don't take where it all started. We care, and for us, we need just to know, or the client remembers a memory where this problem was strong in his life. It can be even yesterday, so we can start from there. BWRT does not use frames, reminder techniques, hypnosis, NLP, CBT, WSM, CD, EFT, BB for brain, anything related to eye movement or anything else you may have encountered. It is unique, effective, and fast. Other therapies seek to modify or remove negative emotional responses, while BWRT works in such a way that the response simply does not arise in the first place. It can be effective in treating almost anything from an uncomfortable feeling, emotion, or habit to a strong phobia, post-traumatic stress, and even behavior problems. If I do a question, what is subconscious and what does it actually do? What your response will be? It really is a part of the physical brain. He receives and processes data and has no emotional connection to the data. Many of them are programmable, so we can modify its processing instructions. We can call this model recognition matrix. But why does the subconscious make us do things we will not prefer to do? It's because what we have always thought of as a subconscious is just a database and models of everything we have ever experienced, which perceives all inputs simply as data to be tested. If that data is known, this part of the brain starts a better match response before we are aware of it, according to the Libet experiments. If you research, you're going to find that Libet experiments shows exactly that we don't have really free will as we think we have. In these automatic responses came from your limbic cortex, otherwise known as the reptilian brain, because far back in time, at the beginning of evolution, it was one of the first parts of the brain to form. It controls things that we do not require conscious thought, such as breathing, sweat, organ function, and the hormonal system. It also controls your way of fight or flight, which is the physical and emotional reaction you feel when confronted with something your brain perceives as stressful or dangerous. This means that some automatic actions or reactions, such as the fear of flying or the need to enjoy something sweet if you feel weak, may stem from misinterpreted or outdated information that your brain has stored from a situation in the past. And it should not even be too far away, in fact. But what happens in a BWRT session? If you have had any kind of experience in counseling or therapy, you may already know that it can sometimes become frustrating, annoying, or even traumatic as your brain ponders back on problems, past and present. But with BWRT therapy, you don't need to discuss the cause or origin of the problem, making the concept of treating feel much comfortable. In a BWRT session, which usually lasts about an hour, the therapist will ask you to target what you do not like about the way you are behaving and feeling, and focus on how you would like to have or to feel. You basically freeze the response before it passes into your reptile brain, instead of allowing emotion or action to form. This is what makes difference to this therapy from other therapies such as CBT. CBT tries to change your response or reaction once the disturbing emotion has already formed. By acting in this crucial and innate position in your brain, BWRT instills more power, but still with realistic beliefs in your subconscious, replacing those old fears or insecurities. By removing that false, frightened, or limited personality and replacing it with what you want to be. It's basically a natural and practical form of therapy, and the best thing is that the change comes completely from within you. When one discovers only a single session that they are free from anxiety that they have been burdened with for years, when someone discovers that they can easily do something that will previously make them scream in fear, when one can deal with a situation that would have previously left them in sorrow, these are moments for which a therapist lives and are treasures to them. How did I get into BWRT therapy? During my studies in university and also after in some training and specialization, I felt that something is missing there. So I always had this question, why should I remind to my client go back in history, go back in trauma, relieve the trauma, then change something. Why doesn't exist something that is faster and you don't need to go all this way? Because as we know, the negative things that happen in lives leaves to us a trace. So why not go directly to the trace that is here now and change it? So I started looking a little bit more and find BWRT in UK. Albania is a small country and psychology culture is not high on anybody's agenda. Knowing that therapeutic session lasts for years, people tend to not search for help. This fact intrigued me and led me to search for new therapeutic approaches that can help me serve a fast and secure therapy to solve mental health issues in Albania. What was needed was such a therapy that is focused in problem solution more than narrative or exploring early childhood traumas. BWRT changed my thinking that people in Albania don't seek help. This turned out not to be true. If I offer my best in the first 10 sessions with the client. But what this therapy gave to me as a psychologist, in these 3-4 years, I noticed that I have become more confident in my therapeutic room. I've seen solutions, I've seen grateful clients, I've seen trust in clients. Clients have more trust to come to me and see me and meet me. I become a well-known therapist because clients start talking about me, about this therapy and what it does. Increase a lot of my work. My schedule is full of clients. Of course, increase of money, because if you have clients, you have money also. From March 2018, in my clinic, I'm offering mostly BWRT therapy, which increased a lot of my appointments. BWRT succeeded in a very short time there where other approaches and medications didn't do for years. Treating more than 3,000 individuals with mental health problems during 2018 and 20 made me the best therapist in Albania and the most known one. I have talked about BWRT, did some TV interviews, some magazine, psychology magazine in Albania, trying to speak about and to let them know about BWRT and the power of BWRT. Telling the truth, during these years, I had only stories of success. So I treated anxiety, GAD, performance anxiety, panic attack, depression, a lot of cases and not more than 3 months in therapy. Insomnia, it's a good therapy that works really fast with insomnia, sleeping problems. OCD also worked in 10 sessions in therapy. Phobia, fear of flight, fear of spiders, fear of snakes, and other sexual dysfunctions, PTSD, and everything around mental health problems. Here I put some testimonials, bio, from my clients, feedback they write it back to me. So here is a 26-year-old girl suffering from anxiety from 4 years. Mixed medication from years, nothing worked, feeling destroyed and lonely. Symptoms, fear to go out to work, fear that I'm going crazy, body tremors, fast heart beating, etc. A friend of her recommended her to work with Adelina with BWRT. And she says, I was hopeless, didn't trust anymore that something will work for me. From the first session, felt the change in me. I was smiling and full of life. Other sessions changed me completely. Way of dressing, living, thinking, and finally I dropped out my medications. Unbelievable. I will surely recommend to everybody to work with Adelina and BWRT. I'm living again my life thanks of her work. You have a lot more fear of flights. This was one of my colleagues and she has a fear of flight. And I did an online session, just one online session with her. And she wrote it back in her wall in social media. Adelina, I'm ready to take off a week of online therapy sessions for my flight fears with Adelina Pietra. So you can watch here. 10-year-old girl, performance anxiety. From preschool, in an activity in front of her peers, she felt anxious. From that, she never stood in front of people to talk. Was the only one from her class that never talked in front of the others. She says, I feel that my brain is empty there, I'm blocked and can't say a word. Applied BWRT, just one session. Next week, she reported, I get up on class 3 times during this week and felt free talking and saying everything I knew. I got 3 A's in math, English, and literature. OCD. This was a Skype session. If I would recall how I felt before, now it seems almost impossible that I felt that way. Stress, anxiety, self-harm that before was part of me for a long time. Thanks to BWRT that for a very short time gave to me excellent results, I feel like I'm reborn again. This therapy made me realize what I was in reality and what I always dreamed about. Before the sessions, I was unable to come up with my thoughts and to be able to feel just a little bit calm. Now I can control the situations. Before, she controls me. The weight of negative thoughts now is disappeared and has completely liberated me from something I didn't want to be. I'm really grateful to you. Insomnia also was an online session, 2 sessions. The girl suffered for more than a year from sleeping problems. Although with medication, she still could not sleep more than 2 hours in the 24 hours bowl. This certainly brought about other problems in performance at work, but also in family and personal life. We did only 2 sessions and now she's really good. I didn't contact me anymore. I want to let you know that this therapy is really fantastic. Nothing that I used before or I had before in my work practice. You can work online, you can apply it online because it is designed this way that it's easy to apply online and to help people around the world fast. But what it felt for me, when I get from my clients those feedbacks, those comments, day after day, I feel so good that finally I'm really doing something, but faster, because these people need to work, these people need to create a family, these people need to live the life now, not after 2 years in therapy or 3 years in therapy, right now. And this therapy, BWRT, gives that possibility to have it. I hope you enjoyed this presentation, and I hope you're gonna look after BWRT and really have it in your toolbox because it's really worth it. Thank you very much. Bye-bye from Albania.
My name is Mlingi Bwire. I'm the Executive Secretary of Zanzibar Psychiatric Association. I would like to talk about the general challenge of mental health in Zanzibar before and after COVID-19. Particularly, we have talked about lack of researchers, data, and lack of psychiatrists, medication, and a few sponsors for fund. So now let us go to introduce our organization and our topic, which is known as a short overview of mental health situation in Zanzibar Island 2020. introduction of Zanzibar Psychiatric Association and its activities. Zanzibar Psychiatric Association is a non-governmental organization which deals with people who are suffering from mental illness and the user of psychiatric service by providing them psychotropic drugs, counseling service, medical checkups, researchers, and income-generating activities among members of ZPA. ZPA work to ensure use of psychiatric service gets the proper treatment, the rightfully deserve, such as provision of psychotropic drugs for few holding seminar of discussion training on the use of UNCRPD and the Zanzibar Mental Health Act number 1 of 2001. The situation of the mental health among residents of Zanzibar Island, generally speaking, is not so good because of lack of researchers conducted on the subject. People with mental disabilities lack enough and reliable data which they can use in dealing with their condition. For instance, in many schools we have no counselors who can provide important information to students on how to deal with adolescents coping with the family stress and the teenagers' hold issues. This lack of researchers and counselors to provide mental health solutions hide a deep understanding of the subject. As a result, our community or society is unaware of the area symptoms of mental illness or disorder. The Islam is faced with the challenge of fewer trained specialists in mental health who can identify and provide guidance among society members on area symptoms of mental illness and which mechanism to use to minimize the effect of the illness. Many families with members who suffer from mental illness also become victims of mental health because no one understands the stress, the struggle they go through in the process of helping their family members, the lack of necessary information on mental health, mental illness, symptoms, and the treatment, which led many families to visit traditional healers who are also ignorant on mental health. This lack of information and research is due to the lack of resources and political interest led to poor community mobilization, which led to creation of stereotypes toward people with mental disabilities, hence discrimination and stigma toward the community of people who suffer from mental illness. After COVID-19 pandemic, coronavirus pandemic have affected so many people negatively. Nevertheless, people with mental disability. First, it has affected people's economic, which this has impacted everyone have mental condition. For those who are job, some lost their jobs, and for people who have been suffering from mental disability, the epidemic left them number. For instance, one number who suffer from fear of death, thanatophobia, and depression, his condition became worse during the pandemic. Also, other 10 members, their condition worsened because of losing their jobs, yet they had no strong support from the government in terms of medication or counseling to minimize the impacts. People with mental disability who have been visited the hospital, many men are facing the challenge of low income, which hide their desire to get the right treatment and the proper medication. ZPA have been receiving medication donations from an Australian psychiatrist, Dr. Gerard McShee, for several years now. This donation has been a life-saving support to Islingers who suffer from mental disability or illness, especially during this COVID-19, because many patients' condition was. Also, ZPA donated the medication received from Dr. Gerard psychotropic drugs for free. Unfortunately, many people still struggle to get transport fee to our dispensary. As the readers, ZPA hears a part-time driver to supply the medication from door to door, step of members who can afford to fetch their medication. This also can indicate that the society is still adamant on its old ways. Many people believe on the use of supernatural powers. The amount of money people use when they are visiting traditional healers is big, contrary to the amount they are using on medication. This calls for more work to be done in sustaining the community that mental illness is real and the disease requires the same effort in treat to just like physical illness. ZPA is working really hard in collaborating with the other partners and the stakeholders, such as National Coordinator of Mental Health, Pemba and Ombudsman, psychiatrists, nurses, local government officials in raising awareness and ensure proper medication to its members. Also, we work closely with PSD from Australia. Dr. Gerard Mix, who provide medication donations and support the overall process of ensuring provision of service to members through ZPA dispensary. Also, another key player is our director, psychiatrist Dr. Mlingi Bwire, who supports ZPA dispensary and the other activities in the association. We also work closely with the psychiatrist nurse Miss Lucy, who support our activities like celebration of Mental Health Day and other association activities in Pemba and Ingrid. We are very grateful to have the support, and we wish to have more sponsors and funders to support ZPA in improving mental health service in Zanzibar Island. Thank you, but I'm grateful to send my thank you to Dr. Viktor, who is the organizer of this conference. Thank you very much. Now, for us, we are preparing for Mental Health Day. As you see our background here, we are on the way for Mental Health Day. Thank you very much.
Hello everyone, I am Fatmagul Mutlu, who is founding director of Bipocos Art. Each year on March 30, we are celebrating Vincent van Gogh's birthday, which is World Bipolar Day at the same time. I'm really honored to attend 4th International Conference on Mental Health Care, and I'm thankful valuable Professor Viktor Vus, and also we will be shared our stage the project called Live Peacefully in the Transmission in Barcelona. This year, because of the pandemic, we are trying to increase our online programs and collaborators from all over. And my presentation topic is Network Maps about Mental Health. European Fund strategies until 2027 includes many priorities for public health area. Political scientists, policymakers, academicians, doctors, public health volunteers, mentors, and more civil society actors have been adapting for social inclusion. All over the world, many countries has been struggling pandemic, and civil societies on mental health area affected economically under pressure of world change. Government policies, private sector attitudes, balance of policies between countries under fear of future. Because of the decrease in resources, global art and health sector and their actors are trying to create new pathways to technology. And I would like to explain European Fund programs taught some explanation of villages. The topic is Humanity, Health, Policy for Creativity. First village, save people around you if anyone needs help against pandemic. Who has mental health problem? How can we fight the related funds and policies? First village in the Europe taught European Innovation Council, enhance European Innovation Council Pathfinder, the Strategic Innovation Agenda, European Research Council, Maria Skłodowska-Curie Actions, and European Green Deal. How can be interdisciplinary? Innovators and visionaries has important role in daily life. Every society struggle with impact of COVID-19 crisis economically. Reglide art projects will archive that public problems taught creativity approach. Most important thing is we should be interdisciplinary benefit groups for humanity. Our pathway is European Green Deal. Governments, private and public sectors collaborations, innovative higher education institutions, education of visionaries, imported social actors, mental health professionals, and project about human for technology. KIC is the most important program by European Commission. Highly autonomous partnership of leading higher education institutions, research organizations, companies, and other stakeholders in the innovation process that tackles social challenges toward the development products, services, processes, and by nurturing. Public health, creativity, and technology. President of European Commission, who is Ursula von der Leyen, has been talking about climate pollution to become climate neutrally on 2050. They have been aiming zero pollution, affordable secure energy, smarter transport, and high quality foods. As an activist artist and director of Bipocos art, I would like to join some topics taught art, zero pollution, affordable secure energy, and high quality food. Environmentally responsible projects should engage reglide art, and we need to create projects that include awareness, but it is not enough for the planet. Every civil society actors needs to aware that we should be define next right move. Awareness is not enough for upcoming future. After massive depressed state during COVID-19 crisis, people have been trying to secure own budget. Governments doesn't afford all budgets. After the crisis, our planet needs high quality food, sustainable energy, and technology for human. End of the first village, we have a question that how can come together around projects taught creativity. My answer is cultural heritage. Cultural heritage for my country is a miniature, one of them. Some of our techniques can't well known for all over the world, like miniature. In the history, artists shared public issues and urban stories taught art. We can start the first village story taught miniature. Many cultures has been trying to continue their culture and attend European Green Deal about climate change. Art is power, and we can use new pathfinders for public health, for visual mapping. And at Bipocos, we have an open call in the theme of biodiversity, and we are using the topic of European Green Deal. Miniature is a special cultural heritage that artists created art taught eco-friendly approach. Miniature is a visual history for many societies. Civil society actors have been collaborating museums, municipalities, private sector, and like that. We need to keep cultural heritage in mental health projects. Another one is lacework as a cultural heritage. You can see the example of textile museums and galleries have some programs for creators. They have been working with children and family programs as online. What about mental health in the collaboration with arts, creativity? Some of points you can see: decision of right networks from all over, regulate arts, cultural heritage, globalization, system securities, digitalization, and human rights. Time is futurism to save health and labor. Many people couldn't make college to become healthy in the name of public health. Museums, TV channels, galleries, fairs, restaurants, and many more sectors have been trying to continue their works, especially as online. Online projects, channels, campaigns was created by main actors. How about people who really need help? Rumi said, if you start walking the way appears. How can keep health individual and group's economy? We should check our bridges and update lifestyle for new normal and continue our works as online and eco-friendly. I and my partners are meeting about right pathfinders and move. Second villages is humanism. People under pressure by COVID-19 who are public and private sector leaders, farmers, authors, artists, project managers, group of disabilities, families, and children from all over. Third village will be included network mapping altogether. Raise your hand. Thank you. And you can see our works www.bipolarprojects.weebly.com and my personal website.
Hello everyone, my name is Giannis Chrysostomou and I am here presenting to you Pyramind Services Ltd. Pyramind is an R&D consultancy firm with 4 core departments. An R&D consulting department, the ICT services department, the market research department, and the strategic marketing department. Regarding, I will now present you the various departments. The R&D consulting department is mainly constituted from people involved into research-funded projects like Horizon, Erasmus+, Interreg, etc. The ICT services department is mostly involved in software development, web development, developing various online platforms like e-health, in-government, inclusion platforms, and of course e-learning. We also have the capacity of creating mobile applications, animated video production, and various blockchain consulting services. Our market research department is mostly has responsibilities regarding managing quantitative market research, qualitative market research, industry-specific technology solutions, etc. And our strategic marketing department offers a wide range of services like market characterization, new product development, etc. I will not go into a lot of details about this. So what I will be talking to you today is regarding how we managed here in Cyprus to stay mentally active during COVID-19 and how we used a platform that was completed just before COVID-19 outbreak to stimulate students' behavior and keep them mentally active during the quarantine period. So, the problem. COVID-19 pandemic means that many students had to stay at home, doing less in terms of social interactions and learning. This can have a negative effect on their physical and mental health since they have to remain isolated. Self-isolation provokes mental health issues. The problem in Cyprus was that pedagogical system was not designed for remote e-learning. The students had to stay at home, and because we didn't have the infrastructure, they were not able to have online lessons in the beginning of the quarantine. They had limited access to online educational material. They were not able to visit historical sites and monuments. They couldn't have any kind of interactive education. And the e-learning platforms were not ready at that time. So, what we did is just before the outbreak of the main outbreak in Cyprus, at least, of COVID-19, a local municipality had just completed an EU-funded ICT project, and we used this project to keep students busy and keep them active during the quarantine period. So, using this platform, the students were able to virtually visit historical sites and monuments all around the city of Paphos. They were able to have access to online educational material. They had access to a participation platform where they were able to exchange opinion and share their thoughts on various local aspects. They were also able to virtually visit the museums and see the various artifacts and about their stories. They were using the technology of augmented reality. They were able to interact with physical monuments, 3D statues, videos, and overall to navigate throughout the city. They were able also to learn about, in an interactive way, the local history with 360 degrees pictures and videos. This project was presented to the students of all local high schools on the 17th of February, just before COVID-19 outbreak occurred in Cyprus. Both students and their teachers were passed this training, and they were informed about the project, which was used at a later stage during the COVID. So now I will present you briefly what this project includes. Its aim was not specifically COVID-19, but its use it was during the first period of the COVID outbreak. It proved to be helpful to all the students and their teachers. So the project was called Collection, Documentation and Digitization of Cultural and Tourist Material, Development of Digital Tourism, Culture and Entrepreneurship Platform, and Development of Digital Application of e-Democracy and Participation in the Municipality of Paphos. This project was funded by the EU program Smart Cities. It had 6 months duration, and a total of 12 people were involved in this for a period of 6 months. It was composed of a total of 3 websites, 2 mobile applications, and it is available in 5 different languages: Greek, English, Russian, Hebrew, and German. So the first output of this project was the main website of Explore Paphos. Students here had the opportunity to see various multimedia information about their own city. They were able to learn things that they didn't know prior to this. They had the opportunity to navigate among various points of interest, see 360 videos, photos, and learn about the overall history of Paphos. This is an example of how one of the point of interests description look like, with picture on top, description below. You may see the details of the location on the map. I will go briefly through this because this is not exactly the point. Further than this, we had an actual map of the city of Paphos where all the points of interest were placed, and students were able to navigate among this. The second platform developed was the historical timeline. This is a timeline putting in a chronological order everything that happened in the city of Paphos over the past years. So students here were able to navigate throughout history and learn about all the important and significant events that occurred during this time. The next platform developed was the citizens' electronic participation. This platform was developed so that people will have the opportunity to participate in the decision-making process during the pandemic. They were able to discuss in an online forum regarding all their concerns. They were able to participate in online polls, to read the news and announcements, participate in consultation procedures, and in general be active during the quarantine period. So in the forum section, they were able to discuss regarding matters that were out of their concerns. They were able to participate in various online polls and speak their opinion about various topics. Okay, so further than this, 2 mobile applications were also developed. The first one was Explore Paphos application, which was again had multilingual content. It had an interactive map with all the points of interest as on the website, and it was also integrated with the Paphos AR application, where people were able to see in an augmented reality form the various monuments. I will be presenting this later on. Okay, so what you see now is how it looks, the mobile application. The 6 major categories are culture, services, map, environment, tourism, and augmented reality. I will not go through all of this in detail, because the point here is that people were able to get this information either from a PC or from their own mobile phones. Okay, so the next application is Paphos AR. So this is an augmented reality application where the various points of interest were placed on an interactive map, and the people were able to watch in an augmented reality view 3D models of videos and various other points of interest. So a digital version of Venus de Milo statues was placed outside the city hall, and So this augmented reality form, it was also very important because people were able to see at their own place videos and statues that were used and restricted by this. Also, this technology can be further used even after the quarantine period is used in other ways, like for example in outdoor virtual museums, because museums in Cyprus closed for a big period. So now there is a need for doing a lot of activities outdoor instead of indoor. There are various solutions that this solution could get expanded. So this is the project, and this is how we dealt in Cyprus regarding COVID-19 outbreak. I hope you liked the presentation, and in case any of you would like to ask any further details or see any links of the actual platforms, you can send me an email directly and I will be happily answering all your questions. Thank you very much for your time.
Hi, my name is Bhawna. I am on behalf of KAB Welfare Foundation. That's a charity which is formed in my mother's legacy. And I'm here to give a presentation on mental health, especially highlighting about loneliness. Thank you. The way a baby is soothed by voice and touch, the way mirror neurons in our brain apparently prod us to feel things that we just witnessed someone else feel or do. The way tickling and laughing are pretty hard to do without our humans involved. Never doubt we are still tribal. At our very core, humans are designed to be connected, loved, accepted and needed. The data from World Health Organization shows that the COVID-19 pandemic has disrupted or completely stopped critical mental health services in 93% of countries worldwide. As the pandemic continues and disrupts routine, even greater demand will be placed on community, national and international mental health services. Health is a crucial prerequisite for sustainable human development, and there can be no health without mental health. Mental health plays a key role in efforts to achieve social inclusion and equity, universal health coverage, access to justice and human rights, and sustainable economic development. The World Health Organization defines mental health as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. Society is changing rapidly. The ways we live, work, and relate to each other are shifting as we move towards a more digital society, as employment practices change and people participate in society in different ways. We are living longer but not necessarily experiencing increased quality of life to match those increased years. Many jobs are becoming more solitary. We can work, shop, travel and interact with businesses and public services online rather than through talking to each other. Feeling lonely often is linked to early death, on a par with smoking or obesity. It's also linked to increased risk of coronary heart disease and stroke, depression, cognitive decline, and an increased risk of Alzheimer. It's estimated that between 5% and 18% of UK adults feel lonely, often or always. And we feel socially rejected. It triggers a response in our brain similar to one from experiencing physical pain. So what are the populations of interest, including vulnerable groups? Although the whole population is affected by the coronavirus disease 2019 pandemic, specific sections of the population will experience it differently, like children, young people, families who are affected by school closures, He might also be affected by exposure to substance misuse, gambling, domestic violence, and child maltreatment, absence of free school meals, accommodation issues, and overcrowding, parental employment, and change and disruption of social network. People with existing mental health issues, including those with severe mental illnesses, might be particularly affected by relapse, disruption to services, isolation, the possible exacerbation of symptoms in response to pandemic-related information and behaviors, and changes in mental health law. Frontline healthcare workers might be affected by a fear of contamination, moral injury, disruption of normal supportive structures, work stress, and retention issues. Older adults and those with multi-morbidities might be particularly affected by issues including isolation, loneliness, end-of-life care, and bereavement, which may be exacerbated by the so-called digital divide. People with learning difficulties and neurodevelopment disorders might be affected by challenges and disruption to support and routines, isolation and loneliness. Society might experience increased social cohesion and communitarianism, but also be negatively affected by increased health inequalities, increased food bank use, increased race-based attacks, and other trauma. Rural communities might also be affected differently to urban communities. Socially excluded groups, including prisoners, the homeless, and refugees, might require a tailored response. People on low incomes face job and face insecurity, cramped housing, and poor access to the internet and technology. A survey by the Mental Health Foundation commissioned for this report found that 48% of us believe people are getting lonelier in general. Loneliness affects many of us at one time or another. Only 25% of us never feel lonely, and 1 in 10 of us feels lonely often. More than a third of us have felt depressed because we felt alone. The pain of loneliness is the sharp end of a milder feeling of a social disconnection that research suggests is a widespread. A recent emotional needs audit of the UK by the Human Givens Institute, which involved 4,600 online respondents, reported that 24.1% of people did not feel emotionally connected to others. 34.8% did not feel connected to the wider community, and 35.4% felt that they did not receive enough attention. Although it's hard to measure social isolation and loneliness precisely, there is a strong evidence that many adults aged 50 and older are socially isolated or lonely in ways that put their health at risk. Recent studies found that social isolation significantly increased a person's risk of premature death from all causes, a risk that may rival those of smoking, obesity, and physical inactivity. Social isolation was associated with about 50% increased risk of dementia. Poor social relationships characterized by social isolation or loneliness was associated with a 29% increased risk of heart disease and a 32% increased risk of stroke. Loneliness was associated with higher rates of depression, anxiety, and suicide. Loneliness among heart failure patients was associated with a nearly 4 times increased risk of death, 68% increased risk of hospitalization, and 57% increased risk of emergency department visits. Despite difference in language, culture, and socio-economic prosperity, all human beings are similar in fundamental ways. We all yearn for love, acceptance, and understanding. People need intimacy, warmth, a sense of self-worth, and a frequent confirmation that they are of value to others. Lack of meaningful human contact is so painful that people will go to great lengths to fulfill their needs for it. This is the time to be slow. Lie low to the wall until the bitter weather passes. Try as best you can not to let the wild rush of doubt scrape from your heart all sense of yourself and your hesitant light. If you remain generous, time will come good, and you will find your feet again on fresh pastures of promise, where the air will be kind and blessed with the beckoning. Poetry helps us shape our loss, heartache, and even our depression in the form of free verse, act, and ambient pentameter. It forces us to confront our innermost thoughts and feelings and provides a comfortable format to be able to share them with others. The report highlights loneliness among vulnerable older adults, including immigrants, LGBT populations, minorities, and victims of elder abuse. It also points out the literature base for these populations is sparse and more research is needed to determine risk, impact, and appropriate actions. Current research suggests that immigrant and LGBT population experience loneliness more often than other groups. Latino immigrants, for example, have fewer social ties and lower levels of social integration than US-born Latinos. First-generation immigrants experience stresses that can increase their social isolation, such as language barriers, differences in community, family dynamics, and new relationships that lack depth or history, the report says. Similarly, LGBT population tend to have more loneliness than their heterosexual peers because of stigma, discrimination, and barriers to care. The current movement calls for each of us to take individual steps to buffer our mental health and to together stand up for greater investment in mental health where we live. We are each managing our own very personal manifestation of acute and chronic stress that dig deep into our biology and trigger both our innate and unique threat responses. This is overlaid on our past life histories and experiences which have already been embedded physically and psychologically. With personal, professional, political, and economic norms so challenged, we are justified in this movement to have a sense of existential crisis as individuals, communities, and as species. Mental health interventions include not only biological treatments for mental illness, which do have efficacy, but more importantly, encompass the various attitudes, practices, and interventions that we each choose and commit to as individuals living with a broader ecosystem of family, friends, local, community, and natural environment. I would like to take the opportunity to share with you some points for optimism both with regard to the steps we personally can take during this difficult time and also from the perspective of what we can be accomplished in the delivery of mental health care. In order to maintain a proper work-life balance, there are certain measures you can take care of your mental health and well-being. Number 1, maintain a routine. You can sleep and wake up at your regular time. You can carry out your morning activities like exercise, preferably outdoors, because ecotherapy is a good de-stressor. Ecotherapy helps lower blood pressure and stress levels. You can exercise for 20 to 30 minutes daily significantly. It reduces anxiety levels, boosts endorphins and serotonin levels in your brain, which helps you to feel good. You can do yoga, pranayama, and meditation. Preferably change into work clothes. It helps when you attend the virtual meetings. Reminding yourself to take notice of your thoughts, feelings, body sensations, and the world around us is the first step to mindfulness. Notice the everyday. Even as we go about our daily lives, we can notice the sensations of things, the food we eat, the air moving past the body as we walk. All this may sound very small, but it has a huge power to interrupt the autopilot mode we often engage day to day and to give us new perspectives on life. Keep yourself regular. It can be helpful to pick a regular time, the morning journey to work or a walk at lunchtime, during which you decide to be aware of the sensations created by the world around you. Every mind matters. There are a couple of ways you can maintain your well-being during this coronavirus outbreak. Talk about your worries. It is normal to feel worried, scared, or helpless about the current situation. Maintain contact with your friends and family via phone and video calls to share how you are feeling. Keep a regular routine and set goals. You may need to set a new routine for now. Try writing a plan for your day with the things you can still do at home, such as watching a film, reading a book, or completing a puzzle. Setting goals and achieving them gives a sense of control and purpose. Manage your media and information intake. If 24-hour news and constant social media updates are making you worried, try to limit the time you spend watching, reading, or listening to coverage of the outbreak to once or twice a day. Do things you enjoy and try something new. Focusing on your favorite hobby, learn something new, or simply taking time to relax indoors should give you some relief from anxious thoughts and feelings and can help boost your mood. Look online for free tutorials and courses. Look after your body. Our physical health has a big impact on how we feel. At times like this, it can be easy to fall into unhealthy patterns of behavior that end up making you feel worse. Try to eat healthy, well-balanced meal, drink enough water, and exercise regularly. You can leave your house alone or with members of your household for one form of exercise a day, like a walk, run, or a bike ride. But make sure you keep a safe 2-meter distance from others.
Hello. Today I speak to you as a mother and as a doctor. So I am a fully qualified medical doctor. I practice anesthesia. I work as a consultant anaesthetist at Guy's and St. Thomas's Hospital in London, which is a big teaching hospital. And I am also a mother. My son fell ill 6 years ago. He was diagnosed with bipolar disorder. He was treated at a world-renowned psychiatric hospital And then he was, when he was deemed to be better, he was discharged so that he could continue his education. But unfortunately, he couldn't continue his education. And at that stage, he had delved into depression, and his general practitioner was unable to identify that he was suicidal. And within 10 weeks of his diagnosis, my beautiful, bright, gorgeous son, who was a drummer and a cricketer, and he was funny and kind, and his last visit to the doctor was 2 days before his death. And through that experience, I learned a lot. I learned about myself, about the healthcare system. This is happening in London, which is the capital of a first world country. So I dread to think what is happening in the rest of the world. So the healthcare profession has pretty much devolved the responsibility for suicide prevention to the public health domain because, you know, many medics believe that there's nothing they can do about it. You know, once somebody's made up their mind, that's it. They can't be helped. Many of them don't know how to ask the question, are you suicidal? Have you thought of ending your life? They don't know how to have that conversation. It's not something we are trained for. The medical curriculum is essentially about physical illnesses. There's very little emphasis on mental illness. So even me, as his mother, I was unable to see that he was suicidal. I could see he was depressed, but I didn't know to pick up the signs of suicidality, sadly. And that is also a reflection of my level of knowledge and awareness about suicide prevention. So I'm here to discuss the gaps in healthcare that need to be addressed if we really, really want to prevent suicide. We cannot leave healthcare systems out of it. So I'm going to go on to my slides now, and I hope you'll be able to see them. So I'm going to talk about closing the gaps in healthcare systems. So I've talked a little bit about Sagar and his story and how I believe that his death was preventable. He had seen the doctors 2 days before. He was in a high-risk category and he should have been identified as such. So we are going to look at what we already know and what we can do as medics. This is my beautiful son, and I miss him so much, so much. It's unbelievable. 6 years have passed and it's like it just happened now. And he had everything to live for, and he would have brought so much light into this world, but I can only talk about how he passed and cherish his memories. We know that recently diagnosed mental illness puts young people at a higher risk of suicide within the first 3 months, which Sagar was in. Several mental disorders put them at a higher risk. We know that. We also know that patients who are recently discharged from specialist care are also at a higher risk of suicide, especially if they're not followed up. We know that patients with history of self-harm or previous suicidal attempts are at a higher risk, right? And Sagar was never actually asked if he was suicidal or if he had history of self-harm or suicide, so suicidal attempts. So that was missed. We already know these things. Patients actually come to us. We know that half the patients who die by suicide have actually come to ask for help from the medical profession, and they've not received help that they needed. So what can we do? Firstly, identify proactively, look for it, because it's really hard. Often people blame themselves when they are suicidal. They blame themselves for feeling like that, especially if they know that they're cared for and loved for and everything is in place and they don't understand what's happening. Often it is not explained to them at the time of diagnosis that feeling suicidal is part of the illness and you will feel like that. But there are things you can do. We keep giving messages of hope and recovery. That's great, wonderful. But also we need to educate the individual and their families about the symptoms of the illness and how it might make you feel. I think we owe that to the patients. Just like with heart disease, we identify risk factors. We do not know when somebody is going to have a heart attack and who is going to have a heart attack. Yet we identify risk factors and we take care of all those people with potential ischemic heart disease who might have a heart attack at any time. Similarly, we need to identify this illness. But for that, we need to change some of our core beliefs in medicine. Many medics believe that they cannot make a difference. They don't know about the brief interventions that they can make to help these people, such as the safety planning. And also, we know that mental illness and suicidality go together. But we should also know that just by treating the mental illness, we are not treating the suicidality. They are two separate things. So Sagar was giving antidepressants, but they would act in 3 weeks' time. But he had been suicidal already for a month. He had said that in his PHQ-9 questionnaire. He had scored 27 on 27. And we will look at some research into that. We also have to know that we don't have to be able to predict suicide accurately to actually address it. We need to address it in everyone with a mental illness. We don't have to be able to predict it accurately because we know these patients are at high risk and they should have it in their back pocket, a safety plan. And they should know that there is help available. So Simon et al. Did this study where they looked at the 9th question on the PHQ-9 depression score, where they found that if the answer to the question, then how often do you think of that you would be better off dead? And if the answer is nearly every day, then it correlates. As you can see on the top line here, you can correlate with the high incidence of suicide. So we can see that it goes on over a period of time. So it doesn't just, it has a predictive value. The 9th question on the PHQ-9 questionnaire. So we have all this information. We know that safety planning is helpful. It was started by, devised by Brown and Stanley for the veterans in America, and now it's used effectively for many different populations. And so the first thing is to identify. The second is to effectively intervene, act, do something. And this is what we can do. So it comes with a template, which gives us a very nice platform to have a compassionate conversation. As we know, often it's not what we do, but how we do it. So, of course, it can be made into a tick box exercise, but let's not do that. Let's use this as a good opportunity to have a compassionate conversation with the patient about what a crisis looks like. It's often for lay people, you say crisis, they don't even know what it means. Like we didn't, because Sagar didn't actually say to me that he was suicidal. He could not say it, but he did write it on the questionnaire. So please look at it. help them identify their warning signs, when to ask for help, identify their own coping mechanisms, such as going to the gym, listening to music, watching Friends, or whatever it may be. Help them identify the people and the settings that will soothe them or distract them, such as their cousins or friends, their music club, their football club, uncles, aunts, their doctor. But this is more like personal resources. And then professional resources, where they can go for help, the numbers they can call, specifically written down so that when they're not in a great frame of mind, they don't have to think, it's ready, available, and they can access it. Include their trusted people. It doesn't have to be family if it is not thought appropriate, although the families know them well and can help them and want to help them. But if they are not deemed appropriate, which can sometimes be the case, ask them to identify people who they trust and include them in drawing this up. Safety plan, making the environment safe. And last but most important is the one thing that makes their life worth living. These individuals have full lives which they are not able to access. It's good to remind them and to help them connect with their life as it is, not as it is now. Viktor Frankl, who was an Auschwitz survivor, said that those who have a why to live can bear almost anyhow. So let's treat them as human beings with a life who have just hit a low spot. Can discharge, follow up, contact, prevent suicidal behavior. Luxton et al. Studied this, and they found that the evidence base for the effectiveness of follow-up contacts for suicide prevention is promising. That means things like postcards, text messages, phone calls or letters from people who have taken care of them in the hospital, when they reach them after they're back in the community. It provides a safety blanket for them. Also, whenever they're discharged from a higher to a lower level of expertise, for instance, from psychiatrists to GPs, it's good if that is taken into account, that the level of expertise is not high. So the handover, each handover has to be proper information should be passed on so that they can be looked after properly. Also, the doors for the specialist services should be kept open so that if they need to come back, if they deteriorate, they can come back without any hurdles, because often that is a big hurdle to get a specialist referral. I will also say that often people who have lost a loved one to suicide, one thing they do not want is for this to happen to anybody else. So please, I'm sure most of them will only want to help and prevent future deaths, because it is the most painful thing for families, and you would never want anyone else to suffer a loss in that way. So please be open to learning from these deaths, talking to the families and saying what they have to, listening to what they have to say and how you can improve your systems and behaviors. So should healthcare systems and providers do more? What do you think? We have so much evidence. I think we should. And can we prevent suicide? Yes, we can. I think we can. But I would plead with the governments all over the world and with the policymakers to please include suicide prevention on the medical curriculum. Let's deepen the understanding of suicidality within medics so that they can actually help individuals. And we have seen that they can help. So yes, let's do something. So we've talked about Sagar, and we've talked about what the things we know and what are the things we can do. This is an article I wrote in 2017, and also this is to remember that as the doctors are humans and we have our own biases, but communication is very, very important. Asking for help, basic things, asking for help, sharing information meaningfully, and actually being trained, knowing about the stuff. Like CPR is mandatory, and because we believe it saves lives. But suicide prevention training should also be made at least available, because right now many medics are ignorant that there is a compassionate and effective way of dealing with suicidal individuals. Thank you very much for listening to me. Thank you.